very dynamic moderator for this session, along with very experienced teachers and support. Right at this moment, Professor Chakravarti has also joined. Welcome, Professor Chakravarti. So all
yes, hello.
Everyone has joined. We are waiting for
Good morning.
Morning. We are waiting.
Morning, Dr. D.
Yes, good morning. Good morning. Professor Ranjit Das, Professor Animesh Das, Professor Sudeep Chakravarti, all the teachers have joined. And Dr. Anshuman is also here. So we are waiting for the students to participate, and we can wait for another 5-7 minutes and start the program. Sudipta, you are getting young day by day.
Myself, I don't know. Thank you, but the people who should appreciate, they are not appreciating.
That's the history of this world.
I'm just making myself off the video, okay? This is a problem for me.
Good morning, everyone.
Yeah.
We do not see the boys. They are also ready?
No, I don't see much boys. Yeah, only.
It is a club for us only. No problem. We can learn.
They will end up, I think we'll have to wait for some time.
Hello. Arjuna? Hello.
Dr. Ashu is not audible. He is speaking something.
Dr. Ashu, you want to say something? You are not audible.
Hey, Arjuna, to me?
Dr. Ashu is not audible.
Sorry. Hello, now I am audible, sir.
Yeah, you are.
Yes.
audible.
Yes, now you.
One.
I will have to brief the today's program. It will be started with two short, long cases. 4 students will be divided to 2 for each session, followed by the session on biostatistics, and then there will be MCQ questions based on these classes today. That everyone has prepared. 17 students have participants are present. We'll have to wait 5 minutes because it's Sunday morning. We'll start it right now.
Till then, sir, we can go ahead with the introduction of our students in this group, in the Geo panel.
You do that.
So, Dr. Dilip, kindly introduce yourself. Where are you from? Check off your audio also. You are visible and audible also, that we can check now. So please introduce yourself.
Good morning, sir. I am Dr. Dilip Singh from IGMS Patna.
Okay. Dr. Kamal.
Yes, sir. Good morning. I am from Kolkata Apollos.
Good morning. Dr. Nawaz. Dr. Nawaz is present. Dr. Kishore.
Yes, sir, I'm present.
Kishore is from which place? Near you.
Medical College, Doctor.
Kishore is from Cuttack, I think, sir. Is he present here or not? I can't see his ID.
to find out.
Is there, switch on your video also, Kishore.
Yes.
Who is, there are two connection from Kishore. Kishore, disconnect one. Who is missing in the link? Dr. Anshu?
Sir,
Which student is missing?
Sir, Dr. Nawaz, I can't see him. Nawaz has also joined.
Oh,
Dr. Nawaz, kindly introduce yourself.
Good morning, sir. Sir, I'm Dr. Nawaz, sir, from RIMS Imphal, sir.
Okay. And Dr. Kishore, he has not yet introduced himself.
Sir, myself, Dr. Kishore Tonge from SCB Medical College, Cuttack, Odisha.
So may I ask you to switch on your video also, Kishore?
Okay.
And to all of the people who are not in the part of this panel, I will ask them to keep their mics unmute throughout the session so that we are not disturbed.
We will just wait another 3 minutes and we'll start the class. Dr. Anshu.
Okay.
Well,
फोन करूं? Sir, I am unable to start my video, sir. Hello.
Hello.
Sir, I am unable to start my video.
You try to leave the meeting once and then join again. See that if you are able to connect with the video that time or not.
Okay.
Otherwise, you can send the video to our office, USI office. It will be played from there, or to your moderator, Dr. Asu. Do both.
No, please allow Zoom to access your from device settings.
Good morning, Kolanda.
Good morning, everyone. Sorry, I am somewhere else. Good morning.
Sir, I think Dr. Kishore has joined again, but he's not able to start his video. We can go ahead with his audio only also. That will be a bit difficult, but okay, we will manage it. So I think we should start, sir, without doing much delay. We should start. Almost 30 participants have joined. All the students of the panel have joined. The teachers have joined, and other faculty members have also joined. And they will be joining in as we go on with our meeting. So should I go ahead, or you want to say something, sir? Ranjande, sir.
Yes, please start the class.
Okay. Okay. So good. Once again, good morning, everybody. As already Dr. Ranjande sir has said, it is a very important topic, the GU infection, which we are going to discuss today. I will just give an outline of what we are going to discuss today. We will be discussing, if time permits, 3 cases. One of them is GUTB, and then 2 cases of pyelonephritis, different types of pyelonephritis that you will come to know during our discussion. So GUTB is a very, very, very important topic, especially in the region, in the country which we live. GUTB is still a major problem that we deal with in our OPDs and in our IPD patients. So it is an important topic both for your practical practice afterwards when you go into the practice, and also before that for your exit examination. Almost I have not seen any examination till date without discussion on GUTB. Cases of GUTB are always there, and one has to be totally knowing of everything in GUTB. So those will be the case discussions. Then I'll be presenting a sort of a lecture on interstitial cystitis, bladder pain syndrome. These are the three things that we are going to discuss mainly in geo infection. Then Dr. Somitro from Tata Medical Hospital, Tata Medical Center, Kolkata will be coming and delivering a lecture on the basics of biostatistics. And in the end, we will have a self-assessment review, self-assessment review questions, 15 questions that you will get. So without doing much delay, I think with the permission of the chair and with the permission of the teachers, I would like to start the case discussion on the first case. I'm going to share the screen now. Is my screen visible?
Yes.
হ্যাঁ ওই দরজা খোলা আছে, চলে এসো, দরজা খোলা।
So I think I will be now starting the case discussion. The first case we are going to discuss. So I think the students, you are ready, and teachers, sir, you are ready. Should I start?
Yes, please.
Okay, sir. Before going to the discussion, I would like to brief to the students also that the questions will be asked by teachers, and one by one, everybody will get the chance to answer questions, but to get a their turn, and they will be answering questions. So all of you have to be attentive, and all of you have to listen to all the questions. It is not like that only one person, one student is going to answer all the questions. So let's go ahead. This is the first case. This is a 32-year-old male who presented with the chief complaint of frequency and nocturia for 1 year. The daytime frequency was around 15 to 20 per day, and in the night time he had to wake up for 10 to 15 times from sleep just to pass urine. He also had urgency and urge incontinence, occasional urge incontinence for last 1 year. Along with that, he presented with burning micturition, sometimes to severe degrees, and then there were occasional episodes of right flank pain. To go further in the past history, there was a history of reddish discoloration of urine 4 years back. There was a history of prolonged cough 5 years back, for which he took a prolonged treatment of around 6 to 8 months at a government hospital. There was no history of hypertension, diabetes mellitus, thyroid disorders, any other medical comorbidities, and there were no significant surgical history.
Let us stop here.
Sir.
Professor Chakraborty, sir, you start. Dr. Dilip.
Yes, sir.
What is the impression up to this point of history? What are the possibilities?
After this history, I would like to put a differential diagnosis, like GUTB, overactive bladder syndrome, and maybe a bladder stone, neurogenic bladder, and urine tract infections.
And urine
tract infection, UTI, sir.
Well, why you are thinking GUTB?
Because there is a history of the cough and pulmonary involvement, maybe and prolonged treatment history. It might be due to the prolonged 6 month or 9 month ATT, tuberculosis, tuberculosis, and there is irritative symptom like urgency, frequency, and history of the hematuria and occasional flank pain. It goes along the history of the tuberculosis, sir. possibility of
Right.
the tuberculosis, sir.
Is there any other possibilities?
It may be the overactive bladder syndrome, because there is more of the irritative symptoms.
Yes. So these
And,
irritative symptoms may be due to other causes. What are the
Yes, sir.
possible? Maybe remote, but
And other possibility like UTIs, dysuria, and irritative symptoms, and occasional flank pain might be upper tract environment.
yes. OIV you have mentioned. Maybe interstitial cystitis even. Maybe
Yes.
chronic prostatitis, back symptoms. Anyway, what about this frequency? What is the normal frequency?
In day, more than 2 to 3 hours, patient goes also more than after 2 to 3 hours.
That means in a day.
In day 5 to 6 times.
Dr. Kamal, what do you think?
So in a daytime, it should be 5 to 6 times, or it should not bother the patients. Hello.
Yes, we are listening.
Yeah, and yes, sir. And in the night time, it should be 1, sir. It should not disturb the sleep of the patient.
So maximum we accept as up to 8 times a day.
Okay.
Well, so how we will proceed, Dr. Kamal?
Sir, in this patient, I also want to know any history of fever in their evening light or temperature or not.
দেখাবো
And
কিছু বলতে চাই
after that, sir, after having some differential diagnosis with us, how we want to go for the evaluation of the patient, sir. First, we start with the basic routine blood investigation, sir.
Yeah.
Hello. Yeah, yes, sir. Routine blood investigation. We'll do a complete blood count. Then we want to do a renal function test. Then we have to go for urine, routine, and culture. And since he has a history of recurrence, so we have to go for some imaging test also in this case.
So, Dr. Ashu,
Sir.
can we have the blood pictures and the
Sir.
Dr. Kamal, you didn't ask for examination. Physical examination is very important part. So, Dr. Kamal.
Yes, sir.
Dr. Kamal.
Yes, sir. I'm listening, sir.
What do you expect in physical examination in this case, particularly if you suspect GUTB?
In GUTB, sir, on abdominal examination, we might find some palpable mass or may not be. There might be some renal angle tenderness might be there. And sir, then we have to go for genital examination and digital rectal examination. In the digital rectal examination, hello, sir.
Hello.
In digital rectal, hello. In sir, digital rectal examination, sometimes we might get some hard nodular prostate or prostatic abscess, boogie filling. And in the external genital examination, we have to look for any ulceration or any scrotal skin involvement, sir. And also we have to see some sign of tuberculosis involvement of the genital urinary system, like if any beaded buses or hard nodular epidermis is felt or not. We have to examine all this.
In DRE examination, what about the seminal vesicle?
Yes, sir. Seminal vesicle sometimes it might involve where it will be enlarged or it will be hard filling can be there.
So if it is
normally, can you seminal vesicle in a normal patient? Can you feel seminal vesicle? Can you palpate it?
No, sir. Normally in normal DRE we cannot feel the seminal vesicle.
So if it is too much distended,
hello,
that means ejaculatory duct is obstructed.
Hello.
Then
I think
you may.
Dr. Sir wants to ask some questions. Sir, please go ahead.
Hello.
Hello, sir.
Sir,
Dr.
please.
Ranjit Das.
Sir.
It's all right. I just wanted to interrupt you regarding the history taking. Is there a necessity for taking a history of smoking in this patient? And number two, in the differential diagnosis, should we consider, since this patient is having severe frequency, urgency, dysuria, hematuria, should we consider the possibility of carcinoma in situ? Although the patient is young, should we consider the possibility of carcinoma in situ?
Dr. Nawaz, you
That
please
was
answer.
my question. A history of smoking in this patient and a possibility of carcinoma in situ.
Yes, sir. Keeping, sir, this irritative bladder symptoms and this storage symptoms predominantly with hematuria. In this patient, sir, we can think of bladder malignancy. However, it is unlikely. This patient has typically history of previous 5 years back history of that cough for which some treatment has he has received. After that, again, she complaining with the same problem and his symptoms, it is increasing. So that is more in favor of this tuberculosis, genetic tuberculosis. Yes, sir, we can keep it as differential diagnosis, sir.
I think it should come much in front of, say, your overactive bladder, at least primary overactive bladder. I think it should come in front of diagnosis. Okay, Dr. Ranjit Das. Okay.
Yes, sir.
Dr. Ranjit Das,
Please continue.
Wanted to say. In the investigations, he asked for the investigations, the blood pictures, the hemoglobin was 12 gram%. The total count was 9,600 with 42% neutrophils and 32% lymphocytes. ESR was raised with 27 and blood urea level was 56 mg/% and serum creatinine was 2.64 mg per deciliter. The blood sugar was 78 mg per deciliter. This was the blood picture. Anything else? So Dr. Ranjit Das, sir, please go ahead.
So Dr. Nawaz.
Yes, sir.
Do you find any abnormality in the blood pictures?
On the sir, blood investigation, sir, creatinine is it is on the higher side. It is abnormal, sir. It is raised. Urea and creatinine. And ESR is
normal.
ESR is also increased, sir.
Well, so if ESR raised, what does it denote?
It denotes, sir, any chronic inflammatory condition, sir, it can be raised. Like into
eosinophil is
like tuberculosis also.
Eosinophil is also a bit high.
Yes, sir, eosinophil, yes. Yes, sir. Eosinophil is also high, sir.
That also you have to take into
yes
consideration. Why? Maybe related to tuberculosis, maybe for some other reasons.
But it has yes, sir. Sir,
bolo.
Eosinophilia, sir, it has to be treated if you are contemplating surgery, any surgical intervention in this patient, sir. Second most is, sir, in parasitic infestations are usually it used to be raised, so it has to be treated if we are
at this point.
Yes, sir.
Well, at this point of time, do you contemplate surgery in this case?
No, sir. This patient, though, sir, I don't think so. First, we need to evaluate properly.
Why you don't know?
Yes, sir.
Yes, you will it not. Well.
Yes.
Okay. Regarding the urine findings, what is the impression?
Sir, slide is still on this, sir. Yeah.
Okay.
Routine urine examination, it is showing, sir, plenty of pus cells, and there are sir, significant, sir, this microscopic hematuria also, but the culture is sterile, sir. So it is, sir, sterile pyuria, sir, with hematuria.
Sterile pyuria. Why? What is the DDs of sterile pyuria?
Sterile pyuria is any inflammatory conditions are involving the urothelium that can cause sterile pyuria. It includes like chemical cystitis, like carcinoma in situ, like any foreign bodies are like stent or stone disease. We can have so these papillary necrosis, interstitial cystitis. These can cause this sterile pyuria.
Anything else? Say his age is 50 years. If his age is 50 years,
Tuberculosis, sir.
what are the other?
Tuberculosis also, sir.
That you have mentioned well, is the first thing.
Yes, sir.
So 50 years old man, how can he have?
Carcinoma in situ, sir. Bladder carcinoma in situ of the bladder.
Even bladder outlet obstruction may also give rise to, even BPH also may give rise to sterile pyuria.
Yes, sir.
Why? Here pH is alkaline. What is the normal pH?
Normal pH, sir, it used to be acidic, sir.
So
here it is alkaline. It should be, sir, acidic if it is tuberculosis.
Yes. That means he might have taken some alkali or.
Yes, sir, most probably.
So
Dr.
now
Kishore,
how we
given the chance to answer, sir. Next question to Dr. Kishore.
Dr. Kishore.
Yes, sir.
How will proceed further?
Sir, I will like to do, sir, ultrasound abdomen pelvis as a extension of the physical examination, sir. Ultrasound, sir. Ultrasound KUB, sir.
USG of the abdomen, not KUB. Why only KUB?
Abdomen and pelvis, sir.
Yes. Okay. Abdomen and pelvis. So here is your USG plate. Please read it.
Dr. Kishore, what are the findings in this USG? Can you please detail it?
Sir, it is not clear, sir, but it is dilated pelvic allocation system, sir. And
upper right frame, you see it is very clear. What is that?
Yes, sir. Sir, it is hydroureteronephrosis, sir. Dilated pelvic allocation system,
Yes,
sir.
and upper ureter also dilated. Well,
sir, dilated.
Okay, the findings of this USG were there was a right renal cyst with parenchymal atrophy. There was grade 4 hydroureteronephrosis on the left side. The urinary bladder was small in size and wall were thickened, and the prostate was normal size.
so Dr. Kishore,
Yes, sir.
you have got it, no? So
yes, sir.
Dr. Ashu, can we go back to the USG again? He is telling right renal cyst. What do you think? Dr. Kishore?
Yes, sir. There is a right, renal cyst, sir, in upper pole of the right kidney.
Well, as it is a sonologist report, so it is very likely right renal cyst, but might be there is a hydrochalicosis also. We are not sure. You have to keep it in mind.
Yes.
So next investigation, what you are doing?
Sir, as patient's creatinine is high, sir, 2.6, sir. I will like to do, sir, MRI, sir. MRI abdomen pelvis, sir.
MRI.
As I'm suspecting
you don't have Dr. Ashu?
Sir, no, we don't have an MRI film.
Sir, I will like to do urine examination for AFB, sir.
Do you have NCCT, Dr. Ashu?
No, sir, we don't have NCCT also for this patient.
Well,
Actually, it
well.
was,
So MRI facility is not there. So how will proceed now?
Sir, as ultrasound suggestive of small size urinary bladder, sir, thickened wall and history. Mostly diagnosis is sir GUTB. So I will go for sir urine for AFB, sir. Urine routine for AFB.
Urine for
we will
AFB.
say- Yes, sir.
What will be your advice? Urine for AFB means how exactly you
Sir,
will
3 to 5.
advise?
Sir, three consecutive day samples. Morning samples, sir. First void morning sample
Well,
for 3 to 5 consecutive days.
then you will advise what?
Sir, urine for AFB, JN staining, sir.
Urine for?
AFB.
You are sending this urine sample. Urine AFB is an incomplete expression. Either it should be urine for AFB culture. Hello, Dr. Kishore?
Yes, sir. Urine for AFB microscopy.
AFB not microscopic. What is the exact advice?
Yes, sir. Bacilli. For
Dr.
routine
Dilip?
staining, sir.
Yes, sir.
Dr. Dilip? How will proceed with the urine examinations further?
Urine has a AFB culture and sensitivity, and the other it takes 6 to 8 weeks. So other test, nucleic acid amplification test may be done, which gives the earlier result.
So exactly what culture you are suggesting?
For Mycobacterium tuberculosis complex, sir.
Bacteric.
Solid medium culture.
You have mentioned bacteric.
Yes, sir. Yes.
What are the types of bacteric culture?
So liquid and
Yes, this
so
is a liquid medium.
yes, yes, sir.
We get the result by maximum by 2 weeks. But
Yes.
bacteric is an incomplete expression. There are two types of bacteric. Can you tell me?
So bacteric fluoroscopic and radiomimetic, sir.
One radiometric. But as there is a radiation hazards nowadays, it is not preferred. So what is the preferred technique?
Sir, we have two types of this bacteric, sir. One is radiometric and second is non-radiometric, sir. A radiometric system, it is based upon the this radioactivity, so it is not done today, sir. Second is this Mycobacterium growth indicator tube, sir. It is actually based upon we have to keep the bacteria in a high concentration of the oxygen. So when the oxygen is consumed by the bacteria, so it fluoresces, sir. It gives a change in the color. So that is MGIT tube, sir. And yes, sir, we can result within this 10 to 12 days.
Well, so MGIT full name is?
Mycobacterium growth indicator tube, sir.
So what is there inside?
Inside will be, sir, there will be fluorescent agent, sir, which fluorescence, sir, which change the color when the concentration of oxygen in that system it gets reduced. When the bacteria will be there, it consumes the oxygen, so this becomes activated.
Well,
the color of the tube will change.
You must know little bit detailed about the constituents of the MGIT tube.
Silicon fluorescent agent tube.
Yes.
Yes.
Yes, sir.
Silicon fluorescent agent is being used in fluoroscopy.
Answer. Dr. Ashu asked you a question.
Okay, sir. He said
What
about
is the
most simple test urine for AFB, that he was saying urine for AFB ZN staining. You said morning sample, you will give 3 consecutive morning samples. The patient is voiding for 10 to 15 times per night. So the first morning sample, will it be sufficient in this case?
No, sir.
No, sir. I think, sir, in this patient, sir, it is very cumbersome. At least, sir, we have to 8 hours of at least collection of the urine we should take, sir. At
Sorry,
least
what collection?
What is the
8
minimum
hours, sir.
amount of urine required for culture?
It is, sir, 50 ml, sir, 50 to 100 ml.
Yes, 50 to 100. So he is passing so frequently. So what you will do? First morning sample it might give you 20 cc.
So I will, sir,
what
collect
you do?
for. I will collect the urine, sir, for at least 8 hours, sir.
8 hours
Overnight,
is
well, but
on the
how,
morning.
how will collect? If you ask him to collect in a vessel, then there is a chance of contamination also.
That should
Well,
be, sir,
you
in
can
the.
collect it here.
That should be in a, sir, specialized that container, sir, and we will explain to the patient about the method of collection, sir, with minimal contamination. And yes, sir.
Sometimes we put a catheter and collect in a closed system.
Okay.
Okay, what other urine investigations you can do apart from ZN staining and various cultures? What other investigations from urine can you do in this case?
1 minute, sorry, 1 minute.
Sir.
The thing is, the urine sample has to be sent to the laboratory as early as possible, because there are certain, elements are there in the urine which definitely damages the Mycobacterium. So that has to be highlighted. That sample should be sent as early as possible. Okay, right. Go ahead.
Okay, now what other investigations can we do, Dr. Kishore?
Sir, TB PCR can be done, sir. Polymerase chain reaction. It gives within 2 to 6 hours report, sir, using urine samples.
Okay.
What is the principle of PCR, Dr. Nawaz?
Yes, sir.
Dr. Nawaz, what is the principle of this PCR or NAT, rather, nucleic acid amplification?
NAT, yes, sir.
How it is done? How do we detect AFB?
The management, the principle is, sir, we amplify, sir, the nucleotide of that bacteria, that the Mycobacterium tubercle bacteria, sir. We increase the amplification of that. Yes, sir.
It is the DNA. DNA sequence, it is detected.
Yes,
typical
sir.
for the Mycobacterium.
Tuberculosis, yes.
Well,
but this is not typical. This is not specific for Mycobacterium tuberculosis. This nucleic acid fractions.
Yes, sir.
BCG strains also they have the same. So it is not very specific for Mycobacterium tuberculosis. And another thing is it doesn't give. What is the disadvantage of this PCR amplification?
The disadvantage is that, sir, we cannot use this for the follow-up purpose. Even in that bacteria that can also give us false positive results, sir.
No, why? Because these nucleic acids are derived from the dead bacteria. So even when the patient has been treated properly, but still there are dead bacteria within. So these dead bacteria, these nucleic acids will be taken up and it will come as a false positive.
False positive.
So Dr. Kishore.
And culture has to be along with.
Yes.
Hello. Anshuman.
Sir.
Anshuman. Regarding this nucleic acid amplification, this nucleic acid amplification is not very specific in urine as it is in sputum. It's mainly recommended for pulmonary tuberculosis, because in GU tuberculosis, there are urinary constituents which inhibit the DNA. scenario. So this is not a very gold standard method. I think when you have the other tests are equivocal or other tests are not positive, then you can go for a nucleic acid amplification.
The WHO has done this X gene part, see, TB, and for that also, and this is more specific for sputum. But nowadays, people are doing also. There are reports that this urine has been sent here and it has been done, and the results are not that bad. These are encouraging and comparable to the cultures.
Sir, can I interrupt for a while?
Yes.
So, present a recommendation to go for RT-PCR, especially gene expert and ultra-gene expert, which has got the advantage of the quickest identification, also to show the rifampicin resistance.
Rifampicin resistance is present or not. Yes,
In
that's what
These
we
are the
wanted to
two
add
things.
here.
Now
In the
it is
recent
as
recommendations,
the,
it is said that in presumptive extrapulmonary TB patients also, if the appropriate specimen from site is available, like in GUTB urine is available, the first investigation that needs to be done is a CB-NAT, the cartridge-based nucleic acid amplification test. That is what the gene expert is. Gene expert, it amplifies the PCR, and in hand it also diagnoses rifampicin resistance. That is very important because of the drug-resistant TB cases. So now CB-NAT is in the recommendations. It has to be done. Anyway, so what are there any other blood investigations that
What is the importance of rifampicin resistance?
Okay, students, Dr. Dilip.
Yes, sir. It is a first line drugs, and if there is a rifampicin resistance, it means in more than 90% cases there will be isoniazid resistance also.
Yes.
So help in treatment.
What do you call that? Both rifampicin and isoniazid resistance. What do you call that?
Multi-drug resistance.
Yes.
Okay, any other blood investigation that can diagnose TB, that can give an indication of TB?
ADS,
More specific.
Or specific?
Difficult, not always available, and costly.
Interferon gamma releases, sir.
Yes. What is the principle?
Sir, it detects interferon gamma, sir. That is the level in response to Mycobacterium tuberculosis antigen, sir. Response to that antigen, it releases the interferon gamma, and the test detects the interferon gamma level, sir. That is not available.
Here I want to. IGRA is not much favored in our country. The reason is that where there is a low state disease, there it is important. But in our country, there is a high incidence of tuberculosis. So IGRA may not give a diagnostic test.
Now, when frankly speaking, another thing is when the number of bacilli is very, very minimum, then these are more sensitive tests.
Sir, proceed little fast. Time is passing by.
Yes, sir. We should move with the imaging investigation. I would like to ask Dr. Dilip.
Dr. Ashu, before going further, I like to ask Kishore very basic thing. How will do AB staining? It will be asked in the exam. Dr. Kishore, can you tell us very quickly how
early morning samples are collected, sir.
Well, it is sent to the laboratory in lab. What will be done?
The smear is done, sir, with ZN staining, sir. First air dry,
sir. Steps of staining, please.
Sir, first smear is done and air dried, sir, followed by air drying, sir, and with heat fixed with heat. And then add 1% HCl, sir, or methanol for fixing, sir.
First is the centrifugation.
Yes, sir.
Then you'll put it in the slide. Then you will
smear
dry it either with dry heat
air, sir,
or with
or
you will fix with
air dried. Sir,
air dried or
SES
absolute alcohol. Put alcohol.
Yes, sir.
After drying, put alcohol. After that, please go on.
Sir,
Then,
sir, counter staining with methylene blue, sir.
Now, before counter, main stain is
no, first,
what is the main?
carbon fiscal, sir.
Carbon
1%.
percent.
Yes,
How
sir.
much carbon percent you will give it?
1%, sir. 1% carbon.
1%. Over flood the slide. Slide
Yes,
should be flooded. Then you will wash it.
yes, sir.
Then you put a counter
then-
stain. What is that counter stain?
Sir, methylene blue, sir.
Methylene blue.
Methylene blue. You'll keep it for 1 to 2 minutes. Oh, sorry, I made mistake. After giving carbon
First,
percent, you have to heat it. You have to heat it.
yes, sir.
You have to heat
Then,
for
sir,
about 5 minutes.
Yes, sir. Then we have to, sir, wash with water. Then we have to, sir, then pour 20% of sulfuric acid also, sir. After that, wait for 1 minute. Then we have to use, sir, this counter stain, that is methylene blue.
Good. Then after oil immersion, you will see it. So it is an important thing. You should know every details. Okay, Dr. Ashu, please go to the imaging.
Urine for AFB, 3 consecutive samples were sent, and in 2 cases AFB was reported. So this was a confirmation of genitourinary tuberculosis. Now with this USG finding of a small bladder and a grade 4 hydrourethronephrosis on the left side, what further imaging investigation? You already said MRI, but MRI was not available in this patient. What else? What other investigation we could do? Small bladder, diagnosis of GUTB confirmed, small bladder and hydrourethronephrosis on one side. What one investigation, one imaging investigation that you would like to do, Dr. Kamal?
The CT scan, non-contrast CT scan we can do here.
What it will give you?
Well, it is
What
not
do you
done.
suspect?
What else?
What do you suspect, and why do you want to do CT scan? What this
Sir,
this
to
will
see any other extra involvement, renal and perirenal involvement is there or not, any other side involvement there or not, we want to see that.
Can you show the film? I can't see the film.
Here we have not done the CT scan, sir.
Okay. With a small bladder, I am already saying the diagnosis of GUTB is confirmed. Ultrasound has shown small bladder. Patient has increased frequency. There is hydrourethronephrosis on left side. What we are thinking is a thimble bladder may be present with VUR on one side, or there may be an obstructive feature. So CT scan, if NCCT is done, it will not be able to give you whether obstruction is present or not. Because if the contrast is not given, you cannot delineate whether there is an obstruction or not. Hydrourethronephrosis, there is total dilatation of the full ureter, so you cannot identify that thing only. Anyway, so MCU is what you need to do, because it will diagnose the thimble bladder also. It will diagnose the presence or absence of BUR also. And if BUR is present, you are already diagnosing it. So we went ahead with MCU. This was the MCU picture.
Yes, sir.
Dr. Nawaz, can you please detail this?
Yes, sir. So this is the, sir, maculating cystourethropy of this patient, sir. It is showing, sir, a small contracted bladder, and the margins, sir, it is irregular, and I can see a small outpouching on the superior surface, that is over the fundus, sir. I think that may be a diverticulum, and there is a bilateral vesicourethral reflex. I can see on the right side it is up to the mid ureter. On the left side, sir, it is grade 4, sir. It is going till the kidneys.
This was the lateral film also showing the same thing.
Yeah. Yes.
So
why these both ureters?
Sir, please go ahead, sir. Dr. Ranjit Das, sir, please go ahead.
So why there is a dilatation of the both ureters? more on the left side?
I think, sir, it can be the consequences of this tuberculosis. Usually, sir, it heals by fibrosis, and there is cicatrical contraction, and that causes uplifting of this this ureteric orifices, sir, and that can cause the reflux, sir.
So you think it is a reflux?
Yes, sir.
So which one is common? Stricture at the VUJ or reflux?
Stricture, sir. Stricture is more common.
No, reflux is common. And here particularly as dye is in the bladder going up, so obviously it is a reflux. But rather reflux, practically reflux is also common. Stricture, yes, stricture can happen. So well, so it is a viewer, small bladder with incompetent VUJ, dye is going into the kidneys. Well, next, I will.
Dr. Das. We should now go ahead with the management part, sir. We are already lagging behind.
Before this, can I interrupt?
Yes, sir.
Hello.
Yes, sir.
Can I interrupt, please? Yes. But the thing is, so the diagnosis is tuberculosis. But now let us have some idea about this process of tuberculosis. What are the different steps? Little bit pathology of tuberculosis. What is the role? How the tuberculosis, in some patients, the tuberculosis is after immediate, when the Mycobacterium gains entry, most of these cases, there is a healing primary. In some cases, 5% cases, there is primary progressive disease. And then again, in another cases, this after latent period of maybe years after, suddenly they flourish up again, the reactivation tuberculosis. So what is the process? Why? Starting, suppose the tubercle bacilli are thrown into the body, then what happens?
Sir,
If there is time permitted, otherwise forget it. This is little bit theoretical pathology, basic pathology of tuberculosis. That is important to understand. Anshu, you decide.
Yes, sir. Animesh Das sir wants to say something, sir. Please. Sir, you are not audible, sir. Das sir.
What is the role of
Patient has
macrophage?
a very small contracted bladder. That's why he has developed reflux. If the bladder was normal, then stricture is more common.
Yes.
If the bladder is normal, then you have ureteric strictures in the lower ureter or mid or upper. Strictures are more common. But when the bladder becomes very small and thimble-like.
You have mentioned about these IF and gamma and all these things. So what are the sequences? How these come one after another in the process of tube?
Yes. So may I answer, sir?
Yes, please go ahead.
Yeah. Sir, genitourinary tuberculosis, sir, usually it occurs secondary to the hematogenous route. It is one of the most common route through which the kidney gets infected. Actually, sir, first it lodges usually in the cortical area.
I'm not asking about genitourinary tuberculosis. I'm asking about basic tuberculosis, Mycobacterium tuberculosis infection. Maybe in the lung part.
Yes,
what
sir.
is
Yes,
the process? What is the pathology?
Yes, sir.
What is the role of different cells? Macrophages, T helper cells, like that. Where from this gamma comes?
Sir, first the aerosol, sir, it infected through the aerosol that come into the alveoli. So alveolar में sir वहाँ पे alveolar macrophage will be there where this Mycobacterium tuberculosis will be taken up by the cell because that is a part of our innate immunity. So now there can be, sir, after taking up there can be two possibilities. One that the macrophage the alveolar macrophage it will kill the bacteria and there will be no immunity and bacteria will be walled off. It will be killed. Second possibility it can be, sir, there can be this bacteria, it will be walled off by the immunity and
Usually inside the macrophage, these tubercle bacilli, they grow on replicating multiplication and all these things. How? Why? Anyway, okay, forget it. Mycobacterium tuberculosis bacteria has got a special power to block the fusion of the lysosome and phagosomes. These phagosomes are actually, phagosomal and lysosomal fusion is most important for attacking and killing any of the bacteria. This process is blocked by the Mycobacterium tuberculosis. And that's how they first go on multiplying like that. But and another, so this is basically at first there is tremendous multiplication only, and there is bacteremia, tuberculous bacteremia also. There is dissemination in the body for 3 weeks or so, and then at that time their patient may have flu-like symptoms. But after that, the bacteria, I mean, this process is suppressed. The Mycobacterium tuberculosis are killed. How? Then what happens? First is the macrophage. Then
sir, this release of this interleukin, sir, interleukin 2 and tumor necrosis factor.
Anyway, okay, this is basic pathology. You see, once the macrophages are activated, and thereafter the T helper cells come. These T helper cells, mononuclear cells come, T helper cells come, and they are most important as far as this containment of the bacteria. These activated macrophages, the T helper cells comes, and the T helper cells also secrete some of these cytokines, particularly for activation of the T lymphocytes. This IL-12 is important. Anyway, and thereafter these macrophages, again, they are activated. They are stimulated by the T helper cells, and the T helper cells then secrete these IF-1 gamma. IF-1 gamma is most important mediator of antitubercular activities. And thereafter, from the T helper cells, again they reactivate these macrophages. And from these macrophages, then tumor necrosis factor is secreted. These tumor necrosis factors are important again for caseation and the necrosis and whatever is there. So anyway, these are the processes by which the body always tries to contain the Mycobacterium tuberculosis. And what is actually the picture, what we find in the tissue? This is not because of the infection of the Mycobacterium tuberculosis, but mostly the damage is done by the excessive host immune reaction. So this host immune reaction is most important, which is caused by these cells, different cells. The picture actually, the fibrosis, the caseation, and everything, it is host hyper sensitivity reaction and increased host reaction because of this infection. That is most important. That's why there is a role of corticosteroids. And it is because if there is no host reaction, suppose there is immune deficiency syndromes, then there is neither fibrosis, nor there is caseation. So the telltale picture of tuberculosis may be absent, as it happens in the immune deficiency syndromes. So you will have to understand this basic pathology. Why there is fibrosis, why there is necrosis, why there is caseation. And in some cases, there is no caseation. Anyway, forget it. Yes, I'm sorry.
Now we have diagnosed the case as a case of GUTB with thimble bladder and bilateral who are present with it. So now I think we should go ahead with the management part, sir. Dr. Ranjit Das, sir, can you take ahead?
Dr. Kishore, now proceed for the management.
Sir, it shows the left side right 4 VUR with thimble bladder, sir. So I will like to do functional studies to see if the left side is
first thing, Dr. Kishore,
yes, sir.
How you outline the management first? Outline.
Sir, first I will start, sir, antitubercular therapy, sir, first.
Very good. One is medical management, then you are going for the surgical management. How will proceed with the medical management?
Medical management, sir, first I will start the intensive phase with sir, isoniazid, rifampicin, and pyrazinamide, sir. HRZ.
I can't follow. It is a 4+.
Sir,
what you are start with?
Sir, intensive phase, sir.
Intensive phase. Intensive with how many drugs?
Sir,
4.
Intensive phase.
Drugs,
4 drugs. For
4 drugs, sir.
For how many months?
Sir, 2 months, sir.
And next?
Then 4 months, sir. 4 months of continuation phase, sir.
Next, for 4 months with how many drugs?
Continuation phase.
Yes, continuation phase.
3 drugs, sir.
3 drugs. But question is
yes,
that
sir.
On the basis of the history of treatment, can you
Yes.
classify this patient? What are the types on the basis of treatment history? We can classify into two groups. One is new cases and another
Yes.
is previously treated cases.
Previously treated or relapse.
So
Yes.
it is basically he has already received full course
Yes,
of
sir.
ATD from history. So you have to
Okay.
consider it as previously treated cases.
Yes.
So if it is previously treated, then what will be the regime?
Sir,
Dr. Nawaz, can you tell me in a previously treated case?
I think sir, secondary line anti-tubercular drug we should start, sir.
Not exactly second line, but regime is very fixed.
Yes.
Regime is, it is fixed by our national body. What is called? Now presently National Tuberculosis Treatment Body is called National TB Elimination Program, NTEP, not RNTCP. Okay, time is short, so I am telling that. So you have to treat with 5 drugs for 1 month. That means you will add streptomycin for 1 month. Then for next 2 months, intensive phase with 4 drugs, what we regularly give, and next 4 months with the free drugs. Okay. From time shortage, we are not going details into that. Hello, Dr. Nawaz.
Yes, sir.
What are the important adverse reactions of these drugs?
Isoniazid, sir, it causes peripheral neuritis, sir, peripheral neuropathy. And rifampicin, sir, it causes all the drugs, sir, it causes this hepatitis also with raised liver enzyme.
Well, you tell me one very dreadful adverse reaction for which we are very scared. Which one you think dreadful?
Ethambutol causes retrovalvular neuritis.
Yes,
Ethambutol causes
it might cause blindness. Very good, very good. Might cause blindness. Now you proceed. Now come to the surgical management.
Now, how you will treat the MDR tuberculosis or XDR tuberculosis? Plenty of cases MDR tuberculosis, almost 20% and 1/3 of the population. I mean, TB patients are at present in the world are going for MDR. And out of this, and about 9%, 6 to 9%, 10% of them are XDR tuberculosis. So you need to know a little bit about it, how you treat.
On the basis of IAB culture sensitivity report, sir,
that is most important. That is most important. You will have to go for this culture sensitivity reports.
Yes, sir.
Yes. And then go on.
The second line.
What are the second lines?
Sir, injectable, paramana salicylic acid pass. Injectables are kanamycin, amikacin, streptomycin, sir. And last one is capreomycin.
But kanamycin, actually, what is the by definition? MDR, XDR, particularly XDR, they are resistant to one of these aminoglycosides.
Yes, sir. Yes, sir.
Apart from fluoroquinolones, also they are resistant to. Okay. So then only goes to then you cannot choose this suppose, but still it may be resistant to amikacin, but it may not be resistant to kanamycin. You have to pick up the drugs like that, or capreomycin, whatever it is. Yes. And how long you will have to choose? How long you will have to continue? Is it again 6 months or 9 months?
Sir, it may extend up to 24 months, sir.
Yes, it is usually prolonged. You will have to review from time to time, and you will have to look for the toxicities. You may have to change the pattern like this. So for our safety, we have to refer these patients to some of these people who are specialists in tuberculosis. Your job is gone. And so you need not answer also. You say simply, I will refer the patient to the tubercular specialist. That is a very difficult situation, very difficult to control, but extremely important. If they need a lot of drugs together, 5-6 drugs together, and it has to be continued for months, 18 months, 2 years or so, and there is a lot of toxicity. So how you will deal? You cannot deal. Better these people, they are meant for that. They will refer them to them. You never hesitate to seek the help of this pulmonologist or tubercular specialist. Okay.
Dr. Dilip, just one question. Dr. Dilip,
Yes, sir.
just tell me what are the newer 80 drugs? Short notes might come in pharmacology. Just name me. What are the newer 80 drugs?
Linezolid, sir, added, and
Linezolid exactly not newer. Anyway, it is used.
Fludi,
One is quinolones group.
yes, fluoroquinolones, already added.
Not fluoroquinolones. What is that? Bedaquiline.
Bedaquiline.
Yes. And another is dilaminate. Just know and try to know details about this drug.
Go ahead with these newer drugs. Further, you search for them and read them. Newer questions will be coming on these drugs also. They have been government approved also for distribution in the programs. Anyway, so
yes. What is the
management,
management?
We should go ahead to surgical management, sir.
Yeah, Dr. Dilip, you
Yes,
start with surgical management.
Sir,
Outline the surgical management.
Goal will be, sir, to relieve the obstruction if there, and to remove the infected source. In most of cases, there will be obstruction of the upper tract, so maybe needed PCN, degescenting.
Extra noise is coming. Extra noise is coming from some source. So what will do? Dr. Dilip?
Yes, sir. The goal will be to relieve the obstruction and to remove the infected foci and augment the bladder since there is a small capacity bladder. So for the relieve the upper tract obstruction, there will be PCN or degescenting. And
do you think there is obstruction in this case?
No, in this there's reflux because of the small size bladder. So goal will be to augment the bladder size.
What is the timings of augmentation?
After the 4 to 6 weeks of antitubercle medication.
After how many weeks?
4 to 6 weeks.
4 to 6 weeks. Why? Why not early? It is emergency, so small bladder, kidneys being destroyed. Why not early?
After the active bacilli replication has stopped.
If you do surgery early, then what will happen? There might be a dissemination of the bacteria. Causing miliary tuberculosis. Which one is very dreadful? What type of miliary? Meningitis, meningeal tuberculosis. Anyway, proceed for augmentation. Well, so usually do it after 4 weeks.
Yes, sir.
Okay. How will you augment it?
Before augmentation, what you need to know?
Bladder capacity.
Bladder capacity is already obvious. What is the okay? What is the usual bladder capacity when you will go definitely decide for augmentation?
Less than 100 ml.
Yes, in less than 100 ml, mostly sometimes the patient may have 30-40 cc's capacity like that.
More than 20, less than
yes.
20.
And will you go for augmentation cystoplasty or substitution cystoplasty?
If capacity is very less, then substitution cystoplasty, sir. Otherwise,
why? In some cases, okay. And before going for cystoplasty, what you need to know first?
About the bowel pathology, because there is bowel pathology that like radiation cystitis.
Another thing you have told that somebody has told that after 4 to 6 weeks of treatment, you go for augmentation cystoplasty and all these things. But I doubt, you see, before you start augmentation cystoplasty, you must treat the disease properly. In an active tuberculosis patient, after only 6 weeks of, will you go for augmentation cystoplast and such a big major operation? You will have to treat the disease. And when most of these people, when they come they with thimble bladder, it is already very late and lot of scar, lot of fibrosis are there. And secondly, what about the kidneys? The kidneys, you need to know whether the kidneys are really viable, whether they are functioning or not. You need to know the function of the kidney. So you will have to go for isotope scan if necessary. You will have to go for GFR estimation because there are a lot of things. If the renal failure, augmentation cystoplast in renal failure also has got its hazards. So you need to know what is their basic renal function. First, okay, proceed.
Augmentation with bowel loops, intestinal. It may be small intestine, a colon, sigmoid colon.
Which one you will choose?
Small intestine.
Why?
Because electrolyte imbalance is less common with intestinal augmentation.
What are the electrolyte disbalance? Usual electrolyte with using ileum or cecum colon.
Hyperkalemia and
You said hyperkalemia.
hypokalemia.
What is the basic, metabolic problem? There is metabolic acidosis or alkalosis?
Acidosis, sir.
Acidosis. And if you use gas stomach,
Urine Cystitis syndrome.
just the reverse, because a lot of hydrochloric acid is being secreted out. So alkalosis in stomach, that's the easy way to remember. So acidosis, hyperchloremia or hypochloremia? In both cases, it is hyperchloremia. In stomach, if you use, what about the sodium?
Hyponatremia.
Secreted
Hyponatremia. Hyponatremia. So basically in ileum, it is metabolic hyperchloremic acidosis. Okay, then why you choose ileum over sigmoid colon? So what is the problem with sigmoid colon?
Ileum behave more like bladder aerodynamically, sir. And
Mucus, sir. Chances of mucus secretion it is more with these things, the sigmoid colon. So chances of
mucus and what about this chances? Is there any chance of malignancy if you use ileum or sigmoid?
Sigmoid mein, yes, sir. Adenocarcinoma.
What do you mean by yes, sir? Chance of malignancy is more in sigmoid if you use the sigmoid colon because of this mixture of these mucus, colonic contents and at the same time urine. So there's a chance of malignancy is more. But in ileum also it is possible. Okay, and another thing is ileum is very easy to move. It has got a lot of redundant areas and you can have a lot of ileum if you can use, and you can move it very easily to the bladder, and we are all accustomed with more with ileal surgery rather than sigmoid or colonic surgery or gastric surgery. These are the reasons. And suppose, but before that, for any augmentation, yes, sorry.
Sir, our time is very short. So ask him. So you tell me, Dr. Kamal, when you use sigmoid colon? Because you listen. One answer is why you do use the ileum. Reason is that we are habituated in seeing it. Our teachers are doing it with ileum. This is the thing. But sigmoid is also very good for cystoplasty. So when we'll do the cholecystoplasty? When ileum is not useful. When ileum is not useful.
The tuberculosis commonly affects the ileum, sir. Ileum pair spaces are there, so tuberculosis involvement is more than ileum. In those conditions, sir, we have to use for sigmoid colon.
Yes, if there is a history of GI tuberculosis, then we have to go for the. Or another question was asked, when you will use the stomach?
Yes.
The stomach is used if the patient renal function is very much compromised. We have to assess the creatinine is high, so we have to see whether renal kidney has got concentrating ability or not by giving water.
Well, there is a high acidosis, and another in pediatric cases, in the smaller children cases, stomach is easy to bring down. In the adult, it is difficult. Well,
so for any augmentation cystoplasty, you need to assess the basic condition of the ileum or colon or whatever it is. So colonoscopy you will have to do first. So you need to know whether that is healthy part or not. Okay.
So, Dr. Ashu, can we move to the next case?
Yes, sir.
It's the time over.
Should I go ahead with the some interesting cases of GUTV right now? Or?
Yes, that is important. If there is time, please.
Sir,
as you wish. You please, yes.
So we already discussed GUTV. GUTV is very important for our examination purposes, and now to conclude it, epidemiologically, it is still prevalent in large numbers in developing countries. Genitourinary TB may be present as involvement of anything starting from the kidney to ureter to the bladder to urethra, testis, epididymis, vas, seminal vesicles, prostate, all the organs of the genitourinary system TB may affect. There should be a very low index of suspicion, which is a must for the diagnosis, as the presentation can be varied. It can be in any form, starting from renal abscess to obstruction to reflux to thimble bladder to anything, chronic prostatitis, anything may be there. So one thing that I would like to add, there are diagnostic criteria set up already by different societies. Now the presence of one major criteria and or presence of two minor criteria diagnosis. The major criteria includes granulomatous lesion on histopathology, which is AFB positivity in urine, or histopathology positive. Then in minor criteria, there are changes which are suggestive of TB on imaging investigations, hematuria, raised ESR, and pulmonary changes that coming a slide about drug-resistant TB, already sir has said. So monoresistant is resistant to one first-line drug. Polydrug is resistant to more than first-line drug, except both isoniazide and rifampicin. Multi-drug resistant includes resistance to both isoniazide and rifampicin. And then there is XTR-TB, in which there is resistance to both isoniazide and rifampicin, plus there is resistance to one of the fluoroquinolones, plus one of the second-line injectable aminoglycoside agents. Now coming to interesting cases, this is a gross specimen of a GUTB case wherein you can see multiple lesions in the kidney, in the renal parenchyma. This is another one showing caseating necrosis inside the kidney, in the renal parenchyma, and completely destroyed renal architecture. This is a case calcified autonephrectomy kidney, which we call putty kidney. This is a simple X-ray of the left kidney showing left kidney putty kidney. This is another one showing putty kidney, a CT scan where whole of the kidney is replaced by a calcified pultaceous material. And this is one IVP. Here in the right side is all normal. On the left side, the as you can see in the zoomed up pictures, there is hydrochalicosis in the superior pole. There is moth-eaten appearance of the inferior pole callisis. Moth-eaten appearance is very important finding on IVP. And then there is a lower left lower ureteric stricture as well, causing upper hydroureteral necrosis. Now this is another one with the calcified right kidney with right upper ureteric calcifications as well. This is an autonephrectomy kidney. We can see calcific focus in the right kidney without any contrast excretion. On the left side, one can see a cutoff at the infranuclear level of the upper tube. There is no left for stricture as well. This is another case, the interesting case, a horseshoe kidney with the right normal moiety and the left moiety showing calcifications and non-excretion of contrasts. This is one interesting case that I would like to say. This patient has autonephrectomy right kidney along with a nephrocutaneous fistula with the calcified fistula tract. One can see here posteriorly. The patient had presented with a leaking sinus over the right flank, and after probing and investigation, it was found to be a nephrocutaneous fistula, and the final diagnosis on histopathology was TB. This is the cystoscopic picture of a gold folio-ureter, what we call the involvement of VUJ, which is the most common site of TB involvement. This is another picture showing right-sided non-excretory kidney on IVPs and on MCU of the same kidney showing vesico-ureteric reflux into the right side kidney. Another CT IVU showing bilateral hydroureter nephrosis with lower ureteric strictures. So there are different presentations that the TB can present. This here we can see the calcification of bilateral seminal vesicles. So seminal vesicle involvement may be there. This is a specimen of tubercular epididymoorchitis with the testis almost completely replaced by a necroting mass. Caseous necrosis is present. And this is one interesting case, a very rare presentation of TB, penile TB. Patient presented with a swelling on the ventral aspect of the penis and swelling in the right inguinal region. The FNAC from the penile lesion showed granulomatous inflammation and caseous necrosis was present. From the lymph nodes also the same FNAC reports was there. It was finally found to be a GOTB involvement of TB of penis. These are some interesting cases that we just wanted to add, just to highlight the fact that there may be a varied presentation of TB. You can get any case in whatsoever permutation and combination. We can have obstruction, we can have a stricture, we can have urethral strictures, we can have ureteric strictures, we can have prostatic involvement, testicular involvement. In females, infertility, tubal blockage, and everything is maybe there. So now I would like to go ahead with the another case.
Anshu, you have 45 minutes left for your session.
Yes, sir.
So there will be one more lecture.
So this is the second case. I think I'm going to start the second case now. This was a 55 years female who complained of right flank pain for last 1 year on and off, which was dull aching. There was no radiation of pain and there was no bowel and bladder disturbances. Since there was sense of fullness in the right flank for last 2 months, fever was on and off for last 2 months, and burning micturition was present for last 2 months. There was history of recurrent episodes of UTI earlier. This patient is diabetic on medications, but not very well controlled. There is no history of hypertension or thyroid disorder or any other medical or surgical comorbidities. On personal history, the patient was non-smoker, non-alcoholic, bowel habits were normal, and there was no significant family history.
Well, so Dr. Kishore, up to this point of history, what is your impression?
Sir, as a patient is diabetic female with right.
Can't see the slides.
No, sir. Thanks.
Can't see the slides. I can't see the slides.
1 minute. Now can you see, sir?
Yes. Well, Dr. Kishore,
Yes, sir. The patient is 55 years diabetic female with right flank pain and fever, sir. Sir, mostly my first differential diagnosis will be right acute pyelonephritis, sir. The patient is having fever, flank pain, and it's a known case of diabetes, sir. And means it is complicated urinary tract infection, sir. Mostly acute pyelonephritis, or second will be, sir, infected hydronephrosis, sir. Or third will be stone disease with pyelonephritis, sir.
So it is some form of pyelonephritis.
Yes, sir. Okay, okay, ji, sir.
Well,
sir. Sir, is
Ashu is showing your examination finding. Well, Dr. Ashu, next slide.
I have already sent him the link.
Next slide. Examination finding.
Yes, sir, on general examination, pallor was present, and systemic examination, there was a soft, abdomen was soft, there was no tenderness, there was a vague lump in the right lumbar region, which was bimanually palpable and palatable. Right renal angle was full but non-tender, and the other systems included examination was within normal limits.
So now what do you think, Dr. Kishore? Will you change your diagnosis?
No, sir. It remains as a infected hydronephrosis or pyelonephritis, sir.
Well, so now you are.
Is there any history of previous trauma or instrumentation?
No, there is no history.
There is no history of trauma. So there is a vague lump palpable in the right lumbar region. Why this lump is palpable? It is a bimanually palpable and velatable. Do you think the acute pyelonephritis will have a velatable palpable lump?
No, sir. No.
There is no tenderness. Another you note it. Parabdominally, there is no tenderness. So you cannot say it is acute pyelonephritis.
Acute pyelonephritis. It's a form, maybe a form of chronic pyelonephritis, sir.
Yes. Chronic pyelonephritis, do you think kidney is palpable?
Sir, it against the chronic pyelonephritis size. No, in chronic pyelonephritis, the kidney is shrunken, sir. Size is small, sir. Sir, there is a xanthogranulomatous pyelonephritis in which the kidney is enlarged and become palpable, sir, in diabetic patients and having stone disease patients, sir.
So, well, you proceed with the investigation now.
No, why not an SOL? Hello.
Hello,
Dr. Das?
Yes, sir.
Hello.
So, Kishore, you should consider SOL also.
This patient presented a long history with a vague pain, occasional fever, and there is a lump, palpable lump. So why not an SOL?
Yes.
Exactly. Dr. Kishore, could it be SOL?
Sir, their chances are of SOL, sir, but patient is having no history of any hematuria or and patient is diabetic, having fever. So more commonly, sir, infectious cause may be there, sir.
And why not tuberculosis?
What percentage of renal SOL has hematuria? What percentage of renal SOL present with hematuria?
10% patient having hematuria.
So 90% do not have hematuria.
So you are saying mostly macroscopic hematuria is mostly absent. Microscopic hematuria may be there. Urine we have not examined yet. Second point is that there is a irregular fever.
Yes.
Could it fit with the Dr. Kishore? Irregular fever?
Irregular fever may be there in case of RCC, sir, as a paraneoplastic syndrome.
Yes. So you
Okay.
should consider
Then
the
maybe
renal
fever.
tumor also. Well,
Consider yes, yes, sir.
And then renal TB is also one of the differential diagnosis. Tuberculosis can also be one of the.
Tuberculosis is also possibility.
Anyway, well, we should go ahead with the investigation part now. We are short on time.
and a big stone in the kidney with thinned out
Yes,
cortex also may be a possibility.
Infected hydronephrosis.
A very big stone.
Sir.
Okay,
Yes.
how will you
Yes.
investigate this case? How will you go ahead with this case? Dr.
Sir,
Kamal.
I will have first.
Sir, yes, we are starting since the patient have a history of fever on and off. We are starting with the blood investigation and the urine analysis. Sir. And urine analysis will go for.
You see the
blood
blood.
investigation.
This is a blood
Yes, sir. Each
investigation.
patient
What
has
to interpret.
the blood investigation count is white cell count is high, neutrophil count is also high, and blood sugar is not well controlled. Sir. Hemoglobin is less, patient is anemic. Then I want to see sir urine.
This is the urine examination.
Yes, sir. Phosphorus are plenty, sugar present, urine CS, E. coli is positive. Yes, sir. So patient is having an UTI along with all these symptoms. So I want to do an imaging study, sir.
Okay, what imaging?
Sir, basically I start with ultrasonography study, sir. I want to do an ultrasound. Whole of the body.
This is the ultrasonographic picture.
Yes, sir. In ultrasound, it shows with hypogenicity and
there is a large,
the kidneys. Here the kidney.
there is a large ectogenic shadow with posterior acoustic shadow also.
Yeah.
There is a stone also.
Yes, sir. We can see the
So
posterior.
this was the USG. The right
Yes,
kidney was enlarged and swollen with multiple hypoechoic areas with a large echogenic focus in the renal pelvis with posterior acoustic shadow. The left kidney was normal. The bladder had internal floating echoes and the other organs were normal. Now, what
Yes, sir.
further?
Sir, I will need to. I want to do a CT scan of the patient, sir.
Okay. This is the CT scan of the picture, these sequential films.
Yes, sir.
This is one, there are 4 images of the sequence, and then there is one more slide. If you are already have seen, I will change to the next slide.
Yes, sir. Please go to the next slide.
Okay, now please give the chance to Dr. Dilip.
Yes, sir.
Dr. Dilip, what can you interpret from this CT scan?
This image show the axial cut of bilateral kidney with right kidney. Show the stone in the pelvis with multiple dilated calyx in right side with some non-enhancing area in the right kidney.
Okay, the CT scan shows enlarged right kidney with perinephric fat stranding with blood fat margins in between the kidney and upper pole and liver. The perinephric fat stranding is present. There is a large stone in the renal pelvis, as well as there is involvement of the right side psoas muscle also. As you can see, psoas muscle is swollen and is edematous, and there is hypotensive region.
श्वास मसल सोलन वोलन है तो बाइमैनुअल बेलोटेबल कैसे किडनी मिल गई? श्वास मसल सूजी हुई है, इनको बेलोटेबिलिटी कहाँ से मिल गई?
No, there is somewhat velatable. It is not, may not be a frank velatable.
Okay, what is your diagnosis, Dr. Kamal, on this CT scan? Dr. Dilip?
Yes, sir. Some gaseous shadow also seen in the kidney.
No, there are no gaseous shadows. There is no gaseous shadows.
It right renal pelvic stone with pyelonephritis.
Well, question is that these non-enhanced areas, is it a water density or something else?
That's a good question.
And what about the function of that kidney? Who is answering? Dilip?
Yes, sir. Parenchyma, it distorted. It means it kidney may be non-functional, sir.
Kidney is non-excreting, so it is a non-functioning
Yes, sir.
kidney. And some films are showing not a water density dilated areas.
Air foci.
Well, next what you want to do is a non-functioning kidney, so you have to prove it by whether it is functioning or non-functioning. How will do it?
Study by nucleotide study. Renograms. Yes, sir.
DTP. Well, it is done.
GFR was
GFR is
53
right kidney.
milliliter per minute. The right side was 3 and the left side was 50 milliliter per minute. Almost 6% right side, 94% left side.
So up to this point of completed investigation, what are your differential diagnosis?
Right non-functioning kidney due to the stone with acute with pyelonephritis, sir. With the diabetes.
Here.
Kidney is very small. The kidney is big. It is not small. In a chronic infection, you would expect the kidney size to be smaller in pyelonephritis, chronic pyelonephritis.
What form of pyelonephritis do you suspect? There is a history of a stone, diabetic patient, no gas shadows, enlarged kidney. Any specific form of pyelonephritis that one should suspect?
Impairment pyelonephritis. Most common
There
diabetes.
is no gas shadows. There is no gas shadows.
Xanthocrilomatous pyelonephritis.
Yes. Calyces are usually dilated, but pelvis is not that dilated. Pelvis is only occupying the stone.
Yes, sir.
One thing, 1 minute. Hello.
Sir, please go ahead.
Before the students, request to the students. You are jumping, you are just throwing one after another without any proper thinking process. That is not expected from the MCH candidates, you see. Somebody is saying epiphysematous pyelonephritis without having gas shadows and all these things. So you must be very careful while you are uttering every words in answer in examination. Okay.
Okay, we should go ahead with the management in this case, sir. So Dr. Ranjit Das, sir, please go ahead with the management.
Well, Dr. Nawaz?
Yes, sir.
Please proceed with the management. There is
the
positive urine culture? Yes.
Yes, sir. Yes, sir. The patient is the counts are raised, sir. Counts are raised, and patient has a big that lump in the lump. I would, sir, like to do first culture specific antibiotic. I will manage conservatively with antibiotic, and at the same time I will see for the blood sugar also, that I will control the blood sugar level also.
Right.
And yes, there is no specific collection, sir. I may think of putting a PCN, but that will not drain all the collection which is seeing on the CT. And later on, then I will plan this patient for this nephrectomy, sir.
1 minute, you said you will do PCN. Why? What is your objective? What do you want to gain in PCN?
Yes, sir. Is patient is sir counts are raised, so I may think of, but it will be not that much helpful, sir, because it is locally.
If you think it is not helpful, why you are uttering?
Yes. Then.
So, Dr. Nawaz, I want to add something. Yes. what is called slip of tongue, you have uttered the PCN well, then you have to stand it. You say, I will control try to control the infection, I will control the diabetes status. If infection is controlled well, I will go for the nephrectomy. Or if you find though there is a high fever and infection is not controlled, I might consider PCN also. Here, this way you will stand.
No, why? How?
Okay.
PCN? What is the indication of PCN? Is there any collection? Is there any pass? Is that what you want to drain? And what you are going to get in a non-functioning kidney by doing PCN? That is what I want to ask. Even if you have said something, it does not mean that you will have to justify it. If you understand that answer is wrong, immediately stop and retreat. Say, my answer is wrong. Don't try to justify. If you try to justify, I will be pressing you one after another. I will just corner you till you submit. So better, if you understand that PCN, your answer is not proper, you say, no, I am sorry, sir. PCN will not be indicated in this particular case. When you do the PCN, either to drain an abscess or to control the infection, and second is to improve the function of a kidney, where the function can be retrieved. These are the two things. So if you find that kidney is already non-functioning, as it is later, and secondly, there is no specific collection of pus or anything, then what is the purpose of PCN? If there is collection of pus, I will drain the pus.
Sir, in some CT frames, it is not a water density. There is a chance of debris also, and that is the infective process is there. As a student, I am arguing, and once I have uttered the word PCN. So,
okay, I understand. Another thing, I'm sorry, please forgive me. The thing is that if in these type of cases, it is well understood in xanthogranulomatous pyelonephritis, usually the virulence of the bacteria is very low. That's why it is chronic infection. Yes. And so patient usually, they do not develop septicemia. So it is not a life-threatening condition. It is a chronic process and low virulent bacteria which is working, and that is the pathogenesis of xanthogranulomatous pyelonephritis. So it is not emphysematous pyelonephritis. Even you can wait for some time before you do the nephrectomy. Or you can straightforward go for nephrectomy because you know the virulence is very low. You give a specific antibiotic for about 2 weeks or so, and then you can go for nephrectomy straight. You know that that is the best way to control the infection.
Let's go ahead with the surgical plan, sir. We have short of time, sir. We are short of time. Let's go ahead with the surgical plan. He said nephrectomy. How would you like to do the nephrectomy, Dr. Kamal?
I have to go for open nephrectomy.
Okay. Can you do laparoscopic?
So laparoscopy, yes, in expertise and can be done, but it's a difficult case since the chronic inflammation surrounding additions are lots of there. So definitely in expertise can be done.
Okay. And in open, what approach would you take?
Since it's involving this, I'll go for some extra peritoneal approach, plank approach, sir, in this case. I don't want to contaminate.
Yes, to prevent contamination, we have to go for the extraperitoneally.
Video games.
Sir, any questions, sir?
Which side you will like? Suppose I ask you choose either right side or left side. Which side you will choose?
Sir, left side will choose. There is no duodenum nearby around, so the left side I will choose.
You will choose left side. Why not right side?
So right side, certain short renal veins are and duodenum also there, so it might involve that part. So localization may be difficult for me, sir. So
yes,
I prefer to go for left.
Remember, yes, you are right. Inferior vena cava may be stuck up totally, and you might land up in inferior vena caval injury, and all this is very difficult.
Vena caval injury and duodenal injury both are very common in XGP cases. Okay, and that was the point we wanted to make in XGP, where one more thing that many a times XGP may present as a renal mass on CT scan. So in such cases, all the oncologic principles of nephrectomy should be taken up, and it should be a radical nephrectomy. So that is very important. You cannot differentiate many a times between a renal mass and a XGP just on the finding of CT scan. So principles of oncology should be applied in the surgery. Anyway, I think we should go ahead with the third case discussion, sir. So would you...
Yes, please.
Little about histopathology. What is the picture?
What is the picture on histopathology? Anybody?
There will be some foamy macrophages will be there, histiocytes.
Lipid-laden macrophages.
What are these called? What are they called?
Sir, xanthoma cells.
Xanthoma cells.
Xanthoma cells.
Okay. And because of these clear cells,
what is the radiological appearance called?
Beer porcine.
Sir,
beer
porcine.
Very good. Very good. Now coming to the third case, we have a 45-year-old female who complained of fever for 5 days, which was high grade associated with chills and rigor. There was right flank pain for 5 days, which was dull aching, which was associated with sensation of fullness over flank, nausea, and occasional vomiting. The burning micturition with increased frequency and urgency was also complained, and patient had anorexia and generalized weakness. On past history, there is history of severe diabetes mellitus on irregular medications. There were no other medical or surgical comorbidities. On personal history, the patient was non-smoker, non-alcoholic, bowel habits were normal, and there was no significant family history. Right.
So Dr. Dilip, up to this point, what are the possibilities?
It may be there since history of fever and flank pain. There may be pyelonephritis, complicated urine tract infection, maybe infected hydronephrosis, and renal mass. Maybe, sir.
Yes, it is acute pyelonephritis.
Yes, sir.
Maybe there is obstructed system with infection. Obstruction may be due to stone also.
Yes, sir.
Dr. Dilip, you said renal mass. Do you think for 5 days duration, a renal mass will present with only 5 days duration?
Maybe hemorrhage with infection, secondary get infected, sir. With after severe trivial trauma, it less likely, but maybe.
Okay.
I think you should, in the exam, with this sort of a history, when it is very far-fetched to say in your differential diagnosis a renal mass.
Yes, sir.
I think you will get into trouble if you say that.
Exactly. Anything with this short history, one should go for all the acute conditions only. Anyway, so how would you like to proceed, Dr. Nawaz?
I would like to do, sir, this baselines or blood investigations.
You don't want to do general examination?
Yes, sir. So, sorry, sir. I would like to do, sir, this general physical examination and local examination. In general physical,
the patient was poor, toxic looking, and febrile. Pallor was present. There was tachycardia and tachypnea. The abdomen there was soft with localized muscle guarding in the right lumbar region. There was tenderness in right lumbar region. A big lump was palpable there, and right renal angle was full and tender. Other systemic examinations were within normal limits. Now what?
My the differential diagnosis, sir, it would be acute pyelonephritis, sir. So I would like to, sir, investigate this patient, sir.
Okay.
With routine blood investigations, including CBC, sir, complete blood count, kidney function test, liver function test, and if patient is diabetic, so I would like to do blood sugar level, fasting, PP, and HbA1c levels, sir.
Okay, why liver function test?
Yeah, if the enzymes will be raised, that may be a part of this inflammation, sir. Acute inflammation.
It is a part of septicemia, then maybe LFT may be deranged. So
does it have any implication on your management? With your physical examination, only the patient looks like septicemic and toxic. It will be there. It won't help anything in your diagnosis, neither in your diagnosis nor in your presentation. So don't utter these things. You will end up in trouble in examination. Just go for focal things only. So the hemoglobin was 7 gram%. There was anemia. There was leukocytopenia with 21,600 count. Urea creatinine was raised. Blood sugar was very high. And HbA1c was also high. So now what?
Sir, I want to do this ultrasonography, sir.
you see nodes. In
Yes,
this
sir.
case, in investigation, in single breath, you have to tell the blood investigation and urine analysis. You should not lose time. Then you go for the USG. At the first
Urine
instance,
analysis
the urine.
showed pyuria, microscopic hematuria, and culture Klebsiella species were present. Now
you
yes.
now you well.
Sir.
Now how will manage?
Yes, sir.
Now you
sir,
should say, I will start the management and I will go for the USG.
Yes.
So this is the USG.
Okay, this is the USG on radiologist report was right kidney was enlarged, swollen with hyperechoic shadows with posterior reverberation artifact suggestive of air in the renal cortex. Left kidney was normal, renal bladder was normal, and rest normal. What further now?
Sir, the ultrasonography, sir, it is suggestive of air, so I will keep that emphysematous pyelonephritis in my mind. At the same time, sir, I would like to admit the patient, resuscitate the patient, and culture-specific antibiotic has to be started. And her blood sugar level, they are very much high, sir. I have to control her blood sugar by giving short-active regular insulin. And after that, sir, then I will plan CT scan, sir.
You see, Dr. Nawaz, first thing you should not say the culture specific. You can say if culture is available, culture specific. Otherwise, I try the
empirical antibiotics. We will start
broad
with
spectrum antibiotics.
broad spectrum empirical antibiotics.
MP.
Now, you said CT. The CT picture is this.
Yes, sir. Sir, this is just a cross-sectional CT scan, sir, NCCT, and that is showing, sir, air foci, sir, within the kidney as well as, sir, outside in the perirenal area, this perirenal area also, sir. And the kidney outline, sir, it looks like irregular and there is no corticomedullary differentiation, sir. It is not that much well appreciable, sir, on the right side.
So from this CT scan, can you classify CT based EPN?
Yes, sir. There is one classification, sir, Hyong and Sang classification, sir, which is based on the CT, sir. Based on this, sir, it is stage.
You tell me the classification.
Yes, sir. Stage 1 is, sir, involvement of the PCS, sir. Stage 2 is when the cortical tissue is involved, sir. Stage 3 is further divided into 3A and 3B, sir. 3A is it is perirenal and pararenal, and 4 is, sir, it is bilateral or emphysematous pyelonephritis in the solitary kidney, sir.
So which stage it is?
I think this is 3A, sir. Looks like 3A. Yes.
Well, so next what you will do? You have started antibiotic, you started controlling blood sugar. You send down investigations.
Yes, sir.
So what you do?
After stabilizing this, sir, we can, sir, I will do, I will try to do this PCN, sir, in this patient, percutaneous nephrostomy. just as a part of my this conservative management, sir. And at the same time, then, sir, I will follow. I will then review this patient. If the patient doesn't stabilize with these measures, then I think then nephrectomy, sir. I will do nephrectomy on that side. But if on conservative management by doing PCN and medical management, if the patient improves, then I will continue with it, sir.
Well, one thing you have missed in investigations, when a acute infective, what is called, very sick patient, you should do the electrolyte.
Have you anybody uttered about this blood culture, isotope scan? What is the role of isotope?
So diabetes is sepsis. So
isotope scan, blood culture. Patient is very toxic and it is almost a fatal disease if you diagnose emphysematous pyelonephritis. And when you will consider drainage, if there is obstruction, in many cases, 20-30% cases, there is obstruction, but it may happen without obstruction. So if there is obstruction, if the kidney function is well, and then you can drain, you can relieve the obstruction, look for improvement if there is any in 1 or 2 days time. And if there is improvement along with the relief of the obstruction, you may continue medical management for some time. In very rarely, some of these kidneys can be salvaged. But in this particular case, almost the whole kidney is damaged. Now, tell me, there are different types of gas shadows in the, within the kidney. What type is more dangerous? What are the different types of gases that you can see in the kidney? And what is more dangerous?
2 types. Type 1 is more dangerous. Type 1 is more dangerous, sir. 40 to 60% mortality rate.
No, sir.
Type 1 is that is mottled dry air, sir. Mottled dry bubbly air.
Not bubbly, sticky.
Dry mottled sticky air and having
which indicates it is mostly in the parenchyma.
Parenchyma restriction. And having mortality 40 to 60%, sir.
Yes. And when there is bubbled, big, lobulated gas shadows, then mortality it is less, about 20% or so.
Sir, there is a fluid, sir.
If there is fluid, if there is perirenal collection, if there is collection in the pelvis, gases in the pelvis, if there is any perirenal collection, if the gases are bigger, bubbled or bubbly, then these patients' prognosis is better.
Yes, sir.
So if another
Kishore,
thing.
Sorry, sir.
Yes, sir.
Very simple way, Kishore, you tell if present of gas with fluid, then prognosis is
good, sir. Good prognosis.
Yes, good.
With fluid is
and
good
if
prognosis.
fluid is absent and multiple motile sticky gas shadows, prognosis is very poor.
Poor prognosis.
Now, important thing is that, Kishore, you tell me, important is you have to assess now the patient. What are the prognostic factors, risk factors in EPN that you have to judge here? Can you tell me the risk factors? Kishore, do you hear?
Yes, sir. Yes, sir.
This is important. Well, Dr. Kamal?
Sir, it is there are certain blood cancers like thrombocytopenia, then sir, patient is in sepsis, then drowsiness.
What is the level of thrombocytopenia, count of thrombocytopenia? Critical count?
Sir, I don't know, sir. I forgot that.
1.20.
I don't know.
Well, so thrombocytopenia, hypoalbuminemia. What is again the cutoff value? Below what you will say hypoalbuminemia?
Below sir 2.5.
Well, 2.5. Ideally below 3. but 2.5 is, yes, lowest limit. Other risk factors you tell?
Presence of sepsis. Presence of
Presence of
sepsis. Yes.
Dr. Dilip?
Yes, sir.
Dr. Dilip?
Yes, sir.
Yes, tell us other risk factors. He told
CNS,
hypoalbuminemia, he told thrombocytopenia.
CNS impairment, multi-organ disfailure.
I can't follow.
So mental impairment, sir. That is CNS
Yes,
involvement.
mental impairment.
And
Disturbance of consciousness.
Yes.
And shock. Shock is initial presentation is very important risk factors. And if acute renal failure, if there is a need of hemodialysis, these are the risk factors. And if it is more than one risk factors, prognosis is very poor. Well, so one thing is that it is a, if creatinine is very high, so you cannot assess the renal function. So here I agree, you have to go for the PCN also, because we cannot do the contrast CT. So and there is multiple gas shadows, and sepsis is obvious sepsis. So you will do the PCN, and if necessary, multiple PCNs. Then what you will do? If everything settled well, who is answering? Dilip here. We are not seeing the Dilip here.
Yes, sir.
Dilip.
Yes, sir. We'll repeat the investigation. I will do the complete blood count and culture again, sir. And physically examine the patient about this subsidence of tenderness and improvement of the symptoms.
You will assess the response of the treatment.
Yes, sir.
By investigation and physical examination.
Physical examination.
Well, next.
If a patient improving, I will continue the medical management.
Good.
Yes, sir.
Later on, you will go for the radionuclide study.
Yes, sir. For the functional studies, control kidney and same kidney.
Or if there is no improvement?
If no, then if maybe emergency nephrectomy or mainly required another PCN to drain the any undrained cavity.
Well, Dr. Ashu.
Yes, sir. So I think we have discussed almost all the points. The main crux was that we have discussed two forms of pyelonephritis, one chronic form and one acute form. In XGP, we can go ahead with nephrectomy as soon as it is diagnosed, because the chances of renal functional improvement is less in future. And we can go ahead with XGP because it is a chronic low virulence disease. But in acute case like Weismetter's pyelonephritis, before going for nephrectomy or any surgical intervention, we should be very, very, very keen on conservatively managing the sepsis part of the condition, so that in surgery, urosepsis, chances of septicemia are very less. So that was one of the important points. Anyway, so we have
one question to this paper. Now tell me another very, very low virulence disease. What is malakoplakia?
Malakoplakia is a defective phagocytomal degradation of the bacteria. Sir. Inside the phagocytes, the destruction of bacteria does not take place adequately. So that condition gives us malakoplakia. It can involve varieties of organs, including the genital organs.
Histopathology, anything specific?
Michaelis Blackman bodies in the later stage, and in the early stage, we can see the interferon
What is the basic defect in malakoplakia?
The phagocytomal destruction of bacteria does not take place. Intraphagocytomal destruction of the bacteria does not take place.
It is macrophage dysfunction, deficiency of macrophage function.
Other participants, please mute your mics. There is too much noise. Noise is present. Please mute your mics, sir. Anyway, now I am going ahead with the next part of our session with this lecture on interstitial cystitis bladder pain syndrome. I would first like to start with a case discussion here also. I think my screen is showing to everybody. It is available.
Yes, yes.
Okay. Now I will start with a case history now. There is a 30-year-old lady who is complaining of symptoms like frequency, sometimes nocturia, lower abdominal discomfort. All these symptoms are present for last 6 months. So what could be the diagnosis? Maybe overactive bladder. So bladder diary was taken. The number of voids were 8 in a day. There were no incontinence episodes. There was no any inadequacy of fluid intake or very high fluid intake, which and the symptoms also did not resolve with antimuscarinic. So the diagnosis of OAB here becomes very unlikely. What else could be? It could be UTI also, but urine analysis did not show any pus cell or RBCs. The culture was especially spicy foods. So this could be interstitial cystitis, or what we now call is bladder pain syndrome. Coming to the historical background of ICBPS, in 1836, it was first described in a text by Joseph Paris and termed tic douloureux of the bladder. In 1876, Dr. Samuel Cross coined the term interstitial cystitis. In the first half of the 20th century, Hunter had described the characteristic lesion on the bladder mucosa, which now is popularly known as Hunter ulcers or Hunter lesions. In 1949, Hand first described the petechial hemorrhagic lesions seen on cystoscopy, which were named glomerulations by Walsh in 1978. Coming to the definition, anything before knowing about anything, we should first properly knowing, we should first be able to define the condition. The AUA guideline defines interstitial cystitis as an unpleasant sensation, which may be pain, pressure, or discomfort, perceived to be related to the urinary bladder, which is associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection or other identifiable causes. So there are 3 main points. It is the presence of an unpleasant sensation, which is perceived to be related to the bladder. There is associated, there is 6 weeks duration, and then there is absence of any other cause for these symptoms. An Indian BPSIC society was formed, and which framed the Indian Interstitial Cystitis guidelines also in 2009. It defined almost on the same lines as recurrent pelvic pain or discomfort of at least 4 to 6 weeks duration, which increases with bladder filling and or decreases with micturition in the absence of definable pathology associated with urinary frequency and or urgency. Coming to the prevalence of this condition, earlier it was thought that it is not very much prevalent in our country, but it is now well established that it is not uncommon in India, and estimated that there are more than 1.25 million patients with this condition in our country as well. So from 2005 to 2015, the India ranked among the top 6 countries using internet, where the Google searches for IC and bladder pain syndrome were taken up. Coming to the natural history of the disease, the symptoms tend to fluctuate, with the majority of patients showing no long-term deterioration. Symptom flares are common and are most commonly experienced for several days. Triggers for flares, they may vary widely among patients. Some have infection, some have exposure to spicy foods or something like that. Prodromal symptoms related to pelvic pain and irritative voiding are often experienced decades before a formal diagnosis. The quality of life in almost all domains is significantly affected, and the ability to function effectively or at all in the workplace is affected to a significant degree by coping skills. Now, the impact on quality of life, as already said, is huge. It may affect the sexual life, it may affect your work productivity, clearly affects the sleep patterns, and then psychological health, causes anxiety and depression. Coming to the etiopathogenesis, the first thing is that it is multifactorial and still it is not very clear. One of the theories says that there may be bladder insult due to various reasons like instrumentation or anything else, maybe prior infection or something else. There may be bladder insult which leads to a damage in the epithelial layer of the urinary bladder, leading to a potassium leak into the interstitium, which leads to activation of C fibers and release of substance P. These activation of C fibers and release of substance P are the main reasons of the symptoms of pain and pressure and discomfort. And this leads to activation of the mast cell and histamine release. This makes a vicious cycle which damages more the bladder more, and hence the vicious circle of this pathogenesis continues and more damage occurs. So in pathology, what are the most important things are the mast cells and histamine. There is release of activation of mast cell which releases histamine, which causes the bladder mucosal damage, which decreases the glycosaminoglycan layer of the epithelium, which increases the epithelial permeability. So anti-proliferative factors are increased in the bladder. These anti-proliferative factors inhibit the repair of the bladder mucosa, which normally occurs in normal persons. There may be neurogenic inflammation and sensitization of neural pathways also, and then nitric oxide metabolism is seen to be increased in these patients. Coming to the differential diagnosis, this is very important. Interstitial cystitis bladder pain syndrome is basically a diagnosis of exclusion. We have to exclude all other possible causes of the symptoms. The most important thing is overactive bladder. The main difference between overactive bladder and interstitial cystitis clinical presentation is that in overactive bladder, the patient presents with an excessive urge to void, but in interstitial cystitis, there is not that much of urgency as there is pain. The patient has pain sensation which relieves on voiding, but in OAB there is urgency and there may be urge incontinence as well. Other diagnosis may be pelvic floor dysfunction, UTI, radiation cystitis, carcinoma in situ, stone in the urinary bladder, chemotherapy-induced cystitis or ketamine cystitis, also called chemical cystitis. Coming to the diagnosis, as I already said, the basic assessment should include a careful history, a physical examination and laboratory examination to rule in symptoms that characterize BPH and rule out other confusable disorders. The baseline voiding symptoms and pain levels should be obtained, mainly in order to measure the subsequent treatment effects so that we can say that the patient is getting treated or not. A cystoscopy or urodynamic study should be considered as an aid to diagnosis only for complex presentations. These are not routinely recommended and are not necessary for making the diagnosis in uncomplicated presentation. Coming to the investigations, the first thing we should do is an urine analysis and culture to rule out UTI. And it must be kept in mind that interstitial cystitis may even be diagnosed with positive culture, especially when appropriate antibiotic therapy fails to treat the symptoms. It may just be an existing infection. Voiding diary is essential for differentiating it from overactive bladder. There may be small volume frequent voiding with pain as the trigger for micturition. In overactive bladder, the patient will say that there is no pain, but we have the urge to void. But in interstitial cystitis, the trigger for micturition is a suprapubic pain or discomfort. Ultrasonography is usually normal, and intravesical potassium sensitivity test was used earlier, but is now not recommended because it flares up the symptoms very much, and it is very problematic for the patient. Symptoms may be very severe with this test. So these are not recommended now, not performed now. Coming to the cystoscopy, the objective is mainly to look for the lesions of interstitial cystitis, that is Hanna's lesions or glomerations. These are not specific for interstitial cystitis, but are very common with this condition, and presence of them indicate well that there may be interstitial cystitis. The capacity of bladder can also be noted with almost most of the cases, the capacity of the bladder is reduced. Cystoscopy may also be indicated to perform the biopsy, and finally cystoscopy may be one of the early treatment also with hydrodistension. Now this is a picture showing the glomerulations. Glomerulations may be present. These are the petechial hemorrhages, submucosal and mucosal hemorrhages, which may be seen on cystoscopy. These are the pictures of Hanner lesions. There is an interesting story about Hanner lesions. When Hanner first described this, he described it as an ulcer, which was later found that there is no ulceration. There is just an erythematous raised patch of mucosa with vessels converging towards it. And later on was found that earlier with the early generation cystoscopes, when Hanner diagnosed this, the light system was so poor that he perceived it as an ulcer and named it so. But now we know that there are no ulcers. Now we call it Hanner lesions. Coming to the cystoscopy grading, the Copenhagen cystoscopy classification of bladder mucosa is present, in which the normal mucosa is grade 0, the petechia and at least 2 quadrants is grade 1, large submucosal bleeding or ecchymosis is grade 2, diffuse mucosal bleeding is grade 3, and mucosal disruption with or without bleeding or edema is grade 4. Coming to the treatment now, the treatment strategy should proceed using more conservative therapies first. Initial treatment type and level should depend on symptom severity, clinician judgment, and patient preferences. The multiple simultaneous treatments may also be considered if it is in the best interest of the patient. Because of their irreversibility, surgical treatments other than fulguration of Hanner lesions are appropriate only after other treatment alternatives have been exhausted. Ineffective treatment should be stopped once a clinically meaningful interval has elapsed, and the interstitial cystitis diagnosis should be reconsidered if no improvement occurs after multiple treatment approaches. These are the guideline statements from the AUA guideline on the management of interstitial cystitis, which came in 2014 and is still the most recent guidelines on interstitial cystitis. AUA guidelines, they have sequentially given the treatment as in first line treatment, second line treatment, third line treatments, and it go on increasing in severity. First, in first line treatments, it is conservative management, behavior relaxation or stress management, patient education, and behavioral modifications. In second line treatment, specific specialized manual physical therapy is used, or maybe oral agents like amitriptyline, sodium sulfate is used. Intracycle therapy may be used with intracycle glycosaminoglycans, heparin, amlodipine sulfate, etc. In third line treatment comes cystoscopy under anesthesia with hydrotension or treatment of Hanner lesions if found. In fourth line management, intraductal Botox injection may be given or neuromodulation may be used with creatine. And in fifth line managed treatments, cyclosporine is recommended. In sixth line and the most severe forms, urinary diversion or substitution cystoplasty may be indicated. Now, treatment according to Indian guideline is almost similar to AUA guideline. Here also state treatment policy has been the standard approach. There are certain differences with AUA guidelines. In Indian guideline, it was said that it was found to, that intravesical botulinum toxin injection is not that effective as thought of, so it has been removed from the protocol. And behavior modification and stress management are always the first line treatments given like the AUA guideline. Coming to specific treatment options now, individually, I would like first with hydrodistension. It is the hydrodistension is done under anesthesia, while technically a surgical treatment is often the first therapeutic modality employed because it is a part of diagnostic evaluation as well in the form of cystoscopy. catheter is inserted in the urethra, or it may be done without cystoscopy also. For that, a catheter is inserted in the urethra to the bladder, through which a saline solution and a drug is instilled into the bladder up to the pressure of 80 centimeters of water. The increase in tension caused by this stretching mechanism damages the afferent nerve fibers located below the bladder mucosa, causing pain reduction. The bladder in IC patients can be very thin, and the possibility of perforation or rupture must always be kept in mind and discussed with the patient. Initial cystoscopic examination has to be performed, and urine for cytology has to be obtained. Bladder is cleared and then refilled to allow observation for glomerulations or ulceration. A therapeutic hydraulic distension follows for another 8 minutes. Biopsy, if indicated, is performed after the second distension. Coming to the next drug, sodium pentose and polysulfate, it is the only oral medication which is approved by the US FDA for the management of BPS. It is the most widely accepted mechanism of action of this drug is the repair of the glycosaminoglycan layers in the urinary bladder mucosa. The main drawback is, as an oral therapy, is that only 1 to 3% of this drug reaches the bladder. So it results in a long course of treatment of approximately 3 to 6 months. And adverse events were very less, occurred in less than 4% of patients at the usual dose of 100 mg thrice daily, and included reversible alopecia, diarrhea, nausea, and rash. Rare bleeding problems also have been reported. Coming to the antidepressants and NSAIDs, combination therapies are effective in treating chronic pain. Based on the use of these drugs is based on the principle that different pathogenic mechanisms can coexist in the same patient, and combination therapies are needed. Amitriptyline, a tricyclic antidepressant, is the most common antidepressant used for BPS and is often the first choice. The various mechanisms of action include its anticholinergic effect as well. Duloxetine or duloxetine, etc. are also other drugs which are used for this condition. Coming to the intravesical gag, hydrodistension in combination with hyaluronic acid with potassium chloride in addition to sodium chloride as a treatment of BPS-IC was used by one study by Daha et al. With the use of KCl and NaCl, pain was improved by 62.5% and 71.48%. Action of intravesical hyaluronic acid was stimulated by instillation of chondroitin sulfate, a substance that blocks the action of lytic enzymes and stimulates proteoglycan synthesis by inducing increased hyaluronic acid levels, thus reconstituting the urothelium. So it is basically about repairing the urothelium so that the permeability decreases and pain decreases. Hyaluronic acid does not provide immediate relief of symptoms, that sometimes is required before the onset of regeneration of the gag layer. Hyaluronic acid may be combined with lidocaine for immediate pain relief. Oxybutynin is an anticholinergic drug with an antispasmodic effect that acts directly on the smooth muscle of the bladder and has local anesthetic action. Normally, it all use intravesical instillation of 10 mg of oxybutynin diluted in 500 ml of saline as a treatment for BPS-IC in comparison with a placebo control, and it showed a 13.33% improvement in voiding frequency and 28.19% increase in voided volume. The vaccine is an interesting treatment approach. The live bacilli from a strain of bovine tuberculosis bacillus is widely used in the treatment of bladder cancer, as we all know. Peters et al. Performed bladder installation of 50 mg of BCG in women with BPS-IC, and the study used bladder hydrodistension as the control treatment. In the treatment group, a 67% improvement in pain was observed, but in the control group, only 29% improvement in pain was observed. Although this is not recommended by any of the societies, but this was one study that came with good results. Coming to Botox, it is a neurotoxin that can cause an anti-nociceptive effect in the afferent pathways of the bladder. It decreases muscle contraction at the injection site. The intravesical local needle applications is used, and Botox A appears to be a reasonable treatment for BPS that is refractory to a standard conservative oral and intravesical treatment. Into sacral neuromodulation, it is an alternative therapy for patients with voiding dysfunction. Purpose of this treatment is to inhibit user action by the electrical stimulation of somatic afferent sacral nerve fibers. The justification for this treatment is based on the existence of a spinal inhibitory systems which are able to stop the contraction of the detrusor muscle. Some other agents
Time
like
is limited. Time is limited.
Miscellaneous agents like methotrexate, arginine, quercetin, nifedipine, all these things have been used. So coming to the take-home message, interstitial cystitis is prevalent in India, which 25 years earlier were thought that India does not have this disease. But now we are seeing it in much larger numbers and it is often misdiagnosed. Pathophysiology is very, very, very complex and it needs multimodal treatment approach as well. Sequential treatment approach starting with conservative management to oral, intravesical, intradetrusor, and finally to surgical approach in a sequential manner recommended by all the societies. Pentose and polysulfate is the only FDA approved oral drug in the treatment of ICBPS, which is used in a dose of 100 mg twice daily for at least 3 months. And treatment with antidepressants and proper pain management is needed to significantly improve the quality of life. Thank you. So anything anybody would like to add, seniors, professors, sir, if you would like to add anything to this with your experience, because I have very little experience and not, the whole talk is mainly theoretical and collected from various papers and literature. So sir, do you want to add something? Chakravarti sir, do you want to add something?
Oh, I thought you were asking somebody. Anyway, no, nothing much regarding this interstitial cystitis you see and BPS. It is mainly we were not interested to diagnose, and we always overlook. That is a basic problem, and that's why we always thought, oh, it's nothing functional, something like that. That was our basic attitude. So unless we are much careful about to pick up these diseases, mostly we miss. And I remember I found these glomerulations in some of our cases, but failed to recognize that some of these ladies may have this IC BPS. Glomerulations are found sometimes while doing the cystoscopy for other reasons. And some of these people, ladies particularly, they go on complaining that there is pain, and which is not really. So in those cases, we should be very careful. We should be mindful to pick up those cases of interstitial ICBPS system. We have also very limited experiences. And unless you are especially interested in these type of diseases to be picked up, you miss them. That's what I feel. Thank you.
Okay. Any other comment from seniors, sir? Any question from the students? Okay. I think Dr. Soumitra Datta has also joined the group now, and I would like to go ahead with the next program in the session, which is a lecture, a talk on basics in biostatics by Dr. Soumitra Datta. I would first like to introduce him. He is a consultant psychiatrist working in Tata Medical Center, Kolkata, sorry, and holds an honorary dual affiliation with the University College London. He is also a lead reviewer with Cochrane collaboration. His current research touches upon psychological and social aspects of health decision making, doctor-patient communication, and pediatric psycho-oncology. He is a research active clinician and undertook MBBS training in RG Kar Medical College and Hospital, Kolkata. He was trained as a psychiatrist in CMC Vellore and subsequently in child and adolescent psychiatry in the UK. He has also worked in King's College Hospital, London and Maudsley Hospital, London. So I would like to hand over the proceedings to Dr. Soumitra Datta, sir. He is very, very keen and interested in teaching all of us about the basics in biostatics, because it is something we mostly ignore all the times. At the time of writing some our thesis or writing some papers, which we routinely do, we usually take help from our biostat colleagues, but don't really go into the details of that and don't even want to go into the details. So sir, please go ahead.
Thank you. Thank you, Antoine. since there have been a lot of lectures since 9 a.m. today, should we give a 5 minutes break? Is that okay? Or you think that will stretch the...
We can go ahead. The students are very enthusiastic. They have no problem.
Okay, so that's fine. Thanks for the introduction. So I thought that what I'll do today was, instead of teaching biostatistics, I think we have all been in this situation where we want to pass the exams rather than learn things in 1 hour. It took me almost 20 years to learn the statistical aspects on epidemiology. So what I thought it would be good for the MCH students is to focus the discussion and the lecture on what matters in exams. So the trick is not to be scared of all these things which look scary, because you will not be expected to be an expert biostatistician. You are all training to be a good urologist, and I would rather have a good surgeon than an expert epidemiologist. So there are always colleagues who would be willing to help, but unfortunately or fortunately, your paper 4, Advances in Urological Sciences, has some questions on biostatistics. So what my current talk I'll touch upon is a bit on the theory paper, familiarize with you some of the concepts. Anshuman had sent me the last few years questions that has come, and also give you some tricks about appearing for exams and how to answer the viva in case you are asked questions. But I have to confess that this may not be an in-depth discussion on each of these topics. Now, if anyone could volunteer, what is the difference between audit and research? Can anyone of you tell us? Can they unmute? Can the audience unmute? Anybody has done any audit during MCH training?
Sir, basically, I would like to say audit is something, studying something which is already present, analyzing something which is already present. And research is when we do a study to find out more things about what is present today.
Absolutely. Thanks for that. So, clinical audit is something which involves measuring our current patient care outcome against an explicit audit criteria. You need a explicit. So if you're doing surgery, so you might have to, say in cancer, you might want to do an audit that was the staging of the patients done appropriately with all the investigations before the patient went on to the surgery, or audit your post-operative wound infection. But there has to be a standard against which you are doing the audit. So you have to mention that before you start. Ideally, in a good audit, you do that. And if you find there is some lacunae, you address that and then do the audit again. And after you do that, that completes the audit cycle. So, and as Anshuman said, that this is not about finding new things, but about making your clinical practice more effective. So doing the right things and doing it right, that's what clinical governance is about. And it's very important nowadays with NABH and insurance being tied up with all that. So I think, you need to not only do these things, but also document them. Now, you could sometimes be able to publish audits, like we published an audit where we looked into the antipsychotics we had prescribed in Tata Medical Center and compared the dose which is given in NICE guidelines or British National Formulary, or because we are just about standardizing the Indian National Formulary. So are we giving more dose or less dose, or at therapeutic dose, and are the indications for which we have given the medication? So is that right? So we did publish it, but there has to be an accepted guideline against which you judge your audit. So that's one question. You might be asked in the theory paper about what is an audit. Coming to the statistics theory, there could be, these are some of the theoretical things. If you have an idea, and I will signpost you for each of the questions which I have seen has come. So types of data is important. So anybody, we will have a quiz in a minute. So continuous variable is something like an age where, the patient may have 19, 20, 21, 24, 26. So it is a spectrum and it varies continuously, and you can have any number between, if it's an adult, between, 19 and whatever, 100, if that's what we are thinking, that usually people die before that. Now, a dichotomous variable is something where there could be two types. You can either be dead or alive. Brain tumors, sometimes now are classified according to mutations. So it could be a mutant or a wild type. Or sometimes there might be, categorical variables like urban, rural. Now, if when, the difference between dichotomous and categorical variables is that you may have more than two categories. In that case, it will be a categorical variable. In ordinal variables, usually there is an order. So mild, moderate, severe. So level of statistics knowledge, low, good, excellent. So there is a semblance of order. There could also be variables like count variables, like number of lesions, number of lymph nodes which are positive, or time to event variables. So, time after the disease diagnosis and death, or time after disease diagnosis and recurrence. So these are broadly the types of variables. And if I now ask any one of you, so based on what we have heard in the last 5 minutes, what would be weight? Would it be, what kind of variable would it be in kilograms?
Continuous variable.
Sorry?
Continuous.
Absolutely. Very good. So the ASA, anesthesia, physical status, what kind of variable would that be?
Categorical variable.
Absolutely. BMI?
Numerical variable.
Yeah, continuous variable. It's a numerical variable. Similarly, you have got the hang of it. So ECOG status will be a categorical variable. Gender would be again a nominal or categorical variable, even if you have more than one, two, now a lot of research doesn't focus only on male or female, but even then it will be a categorical variable. Now, you can make a continuous variable into a categorical variable, and I'll tell you why, because in a minute I'll tell you, because you have had questions when to use which test. So say a continuous variable which is weight, if you divide your study group, say you have 100 patients and those who weighed more than 60, you classify them as higher weight, and those who weigh less than 60, you classify them as lower weight. So you are changing a continuous variable into a categorical variable. Sometimes that's done. Similarly, BMI, you can have somebody with underweight or healthy weight or overweight or obese. More than 30 BMI is obese. So a continuous variable is changed into a categorical variable based on a standardized cutoff. Now, when you express data, the whole purpose of statistics is to, summarize. So if we have now 46 people attending this class, I might want to summarize that, 5 or 6 are faculty and 40 are students. So the moment we go into a proportion, that's a summary. I don't have to call out all the names. Similarly, we might want to, for the students, want to get the average age. So one number will represent the average age of all the students attending this lecture. And of course, these could be graphs, as you know, but I won't cover graphs. So if you have weight in kilograms, and that's a continuous variable, all these three are continuous variables. And if they're normally distributed, what is the summary statistics or the average statistics that is usually used? Can any of you tell us? So it's mean plus minus standard deviation. And if it is not normally distributed, then mean is not used, median is used with interquartile range. And I'll tell you in a minute how you would understand something is normally distributed or not normally distributed. Now, before we go, there is also some questions on sensitivity, specificity. I'm not going into that, but these are for categorical variables and usually is done for 2 by 2 tables. So say there is a disease, which is the truth that somebody has the disease or does not have the disease. They can't be in cancer, you can't be somewhere in between. And there is a test which detects it correctly and sometimes gives false negatives and sometimes gives false positives. So from that, we can calculate the sensitivity and specificity of a test. We would like a test to be highly sensitive and highly specific, but it's difficult to be, 100% sensitive and 100% specific. It's almost impossible to get that. So that's why this statistics is done. So there is a full lecture in our research methodology course on that, but because of the shortage of time, I won't go into the details. It's 12:37 and I hope that I'll finish before 1 o'clock. Now, when you say have the age of all your participants, and if some of them, may have got this into very early into your, 1 second. Some of you may have got into, MCH course very early on, but you started your MBBS maybe at 17 and got into MCH course at 23, but that will be rare. So someone who is very young would be rare. Most of the people would be in the middle part, and there would be some who may have got, delayed for whatever reasons and started the course a little late, but that again would be rare. So when you distribute any variable, and this is the frequency in this axis, and say the actual value, which is age and frequency. So usually if you study a large number of people for anything, it could be height, it could be, this is only done for continuous variables, it would give a normal distribution pattern. Now, say for performance, if we take a statistics, exam, so most of us would be, we would meet the expectations, and in the middle, some would be exceptionally good and some would be underperforming. And that's how most normal phenomena are. Now, there is ways in statistical softwares where you can actually check. So in a normal distribution, mean, median, and mode are all same, and it's in the center. And the two sides are symmetrical, and the asymptotic tail, is symmetrical both sides. Now, how would you know if you study 100 people and say you are studying, are you a very young dashing surgeon and getting only young men coming to you or very older folks coming to you. Now, knowing that you are urologists and you might be operating on prostate cancer, so chances are that you would probably operate more on elderly. So now, if you want to see if your patient group is following a normal distribution or a particular age group prefers you, you might have to check the distribution of the data. Now, there is, so, the skew of a data is, this is a slightly blurred. So where it is, the majority of people are on the right side. So higher numbers are more represented. The skew is in the left. So whichever side the tail is, you determine the skew. So this is skewed to the left, and this is skewed to the right, and this is not skewed at all. Now, you know this bottle, isn't it? Smirnoff vodka. Now, when you are trying to deal with a data set and you don't know it is normally distributed or not, there are 3 tests you could do. So the statistical software, sort of plots the normal distribution, and your data might be this, and it does a test. And if it is significantly different, then you can say that your distribution is not normally distributed. And the tests which do that is Kolmogorov-Smirnov test and Shapiro-Wilk test. Now, why this is important is, for normally distributed data, you can use parametric tests. And data which is not normally distributed, you use non-parametric tests. So, these few concepts, because your paper 4 is a theory paper, if you write these things and throw in these, terms, I think you will get the pass mark. So when you are comparing 2 independent groups, so mean, people with Dr. A versus people with Dr. B, and trying to see the age between the 2 clinics. So that is unpaired. Dr. A has nothing to do with Dr. B. So then you can use, and if you have large number of patients, you could use a parametric test. You have checked for normality, and you can use an unpaired t-test. Whereas if you are sort of trying to see, PSA level before treatment and after treatment, both are continuous variable, but it is paired because the same person is being tested twice. So then you use a paired t-test, and it has to be a parametric data. Now, if these are not parametric, not normally distributed, then you use, Mann-Whitney U test when there is 2 independent groups, and more than 2 groups, you can use ANOVA test when they are normally distributed, and you can rank them and use for non-parametric, these are the tests. So I think if there is a short note on parametric versus non-parametric tests, and you give a concept that you use, just remember the t-test, chi-square test for 2x2 table, Mann-Whitney U test for non-parametric, it's usually done, ANOVA for more than 2 groups, and again, chi-square you can use for more than 2 groups, and ranking them, I think you would have some idea. Now, when you are trying to do causation, so say age, and for a children's group, age and the class the child goes to. Now, you would expect an older child to be taller, or, so age of a child and height of a child. Now, both, if they're normally distributed and you have taken enough number of children, you would use a correlation coefficient. And if there are more than 2 groups, you use a linear regression. If you have divided them like we did earlier, higher weight and lower weight, you do regression like logistic regression. There is also a short note on p-value. So I think a p-value is the measure of the probability that an observed difference could have occurred only by random chance. Whereas if the p-value is lower than that, you accept. So, lower p-value is better for most of the things. So, and this cutoff of 0.05 is an arbitrary cutoff. This again is a full lecture, but I won't go into the details of it. But if you have a look at, and remember this, you would be able to answer some of the questions which might come. Now, what are the levels of evidence? Questions also has come, types of study design. So I think, if you study these both together and write the same answer without, just changing the name, you would sort of get it. So study design could be a single case report or a case series. Is it good or bad? It's not bad, because many of the important study, diseases today, say HIV, Alzheimer's disease, Parkinson's disease, have all started with description of a few cases. A clever doctor had observed them and found that these symptoms come together. However, I think, in nowadays, if you are trying to see, you have to do larger studies. So we are just above the pandemic, and you could see that the amount of research which happened in the initial part of the pandemic about the cause of the disease. Now, after cross-sectional studies, you do case control studies. I'll talk in a minute. Cohort studies, randomized control trial, where you give the trial intervention for one group and the comparator intervention for another group, is a gold standard. And systematic reviews is where you summarize the findings of randomized control trials. Now, what is a case control study? Case control design is the disease has already happened. So this is the case, and this is the control where disease has not happened. So say somebody who smokes and has developed, bladder cancer, whereas the person has not smoked, but even non-smokers also develop bladder cancer. Now, when you measure bladder cancer, you also, if you have a control group, they will also have, you have to measure who smokes and who doesn't smoke, because the same exposures have to measure for the cases and controls. And if you see that there is more prevalence of smoking in the case group than control, then you might say there is an association of smoking with bladder cancer. And the study begins after the disease has happened, and you go backwards. In a randomized control trial, again, this is a short note for you. Don't bother about parallel group, crossover, RCT, but the things to be understood is, first of all, is randomization. So nowadays there are computer-based randomizations. So if you give that you have two arms, 1 and 2, and you want to randomize 30 numbers, so you could very easily get a random, say 1, 1, 2, 1, 1, 2. The computer will tell you the sequence. Now this sequence is often produced centrally. So in an all India trial, somebody might be sitting in Bangalore or Delhi and has the sequence. And once you recruit a patient, your trial coordinator calls up the central number and they ask, this is the number and which envelope should I? So you also don't know, you will get into the study group or case group. Usually they have a number. The vials look the same, the control and the case, but you are told that you pick up this number of the box and administer this medication, and the trial coordinator administers the medication. Now this randomization process can also be done with envelopes, but usually it is done centrally through computerized. If there was time, I could have shown you, because there are random number generators online as well. Now, allocation concealment is after the randomization, the allocation remains hidden and concealed. So I will show you in a minute where, so this is like, the drug A, drug B, and the random numbers the computer has generated 22211, 2211. And if you can see that the arm which goes to, the first patient goes to arm 2, second patient goes to arm 2, third patient goes to arm 2, fourth patient goes to 1, so on and so forth. But, for surgical patients, you will know, you won't be blinded, because you will know who is getting surgery and who is not getting surgery, but you won't be be able to modify which arm your patient who is in front of you goes to. So blinding may not be possible, but randomization is possible. In blinding, what happens is you withhold the information about the assigned intervention from the people who are conducting in the trials. And so there could be single blind, there could be double blind, there could be triple blind. Triple blinding is, so first single blind is where the assessors don't know, double blind is assessors, trialists, the patients also don't know. And in triple blind, the statisticians also don't know which group the outcome they're analyzing. I would request you, all of you, to have a quick glance. This is a 2-page document called Consort Guideline. It will give you a gist of what is a good randomized control trial. So what we had discussed, so randomization after your eligibility is assessed, you meet the criteria, randomized, and then you put into the allocated into intervention 1 versus intervention 2. And for some reason you would have some patients who might drop out at that stage. So allocation is this, and you remain blinded to this. And this process of allocating into one arm or the other is based on the randomization process, whereas the allocation concealment happened at this stage as well. So I think you would have understood what is the difference between allocation concealment and randomization. Coming to meta-analysis, as a Cochrane reviewer, I think you should understand what these lines stand for. So when the line crosses this middle, that's the line of no effect. And each of these are trials. And the whiskers along the sides are confidence intervals. And at the end, there is a diamond, which is the overall effect and measure of the effect, which is the summary statistics of each of these trials. So if you see, so streptomycin for myocardial infarction, this is a very well-known meta-analysis. So there were trials from 1959. And this is a cumulative meta-analysis. And if you see, trials continued to happen till 1988, whereas if somebody had done a meta-analysis, this obviously was done in 1992, the meta-analysis, we could have stopped doing trials in 1973, because by 1973, superiority of one treatment was clearly shown over the others if we had done a cumulative meta-analysis. Now, there is a question on sample size for you. I think all randomized control trials should have a formal sample size estimation. So in all RCTs, if your sample is too small, you may get something called a type 2 error. So even though the intervention is effective, you will fail to capture the effect. Whereas if you have a too big a sample size, then you might be unethically randomizing people into treatment and intervention arm, whereas you already know that one arm is better than the other. And meta-analysis can help in collating several small studies, as I was mentioning, into your summary statistics. So as I said, we could have stopped doing these randomized control trials in 1973. 15 years, so much money spent, so many people. You can see the number of patients by the time it was this, huge number, 17,000 people were randomized. And this is myocardial infarction. They would have clearly benefited from streptomycin. I've finished about the theory. In the last 2-3 minutes, I'll give you some tips about the viva. And I think these goes, because of the many exams I've taken. So both here and abroad, I think it's important that you don't take an extreme stance in any viva exams. So say somebody is asking you a question on a robotic technique versus open surgery. I know it's probably a controversial topic to talk about, but you don't know, your examiner might not be the particular person who is very fond of a particular technique. So I would suggest that you take a moderate stand, that in studies demonstrating superiority of one technique over the other, try to understand the question. So this is not a banter. So it is not a conversational game between you and the examiner. If you need few seconds to think, you say, can I think for 10-15 seconds? Take a few seconds. A minute may be too long, but few seconds. If not sure, reframe the question. Because how politicians answer. If they're asked a question, they often, first few seconds, they are thinking about what to answer. So you say that this is a study which has been There has been studies which are done against where patients have received this intervention versus that intervention, and the outcome assessment was survival or quality of life. And while you are telling this, you are thinking in your mind what to say. So I think reframing the PICO, patient intervention comparator outcome, at least will tell you that you have a systematic way approach to the question and then give the result. Also interpret the result as applicable to your clinical setting, because that's very important, because you are not being judged as an MCH trainee to be a researcher. You will be a surgeon. So if you're asked about, say, choice of antibiotic in the post-operative setting, and somebody is quoting a study, give your views as what is applicable in India. So I think these are my Viva tips. I have come to the end. I could conclude that the purpose of statistics is to summarize data and test a hypothesis. Whatever is statistically significant may not be clinically significant. You have a large sample size, you will get a statistical significance. But say a survival, which is only 2 weeks more in the intervention arm as a comparator, does it actually really matter to the patient? So ask yourself that question. I would end by a quote with Richard Feynman, who is a Nobel laureate, that with what one fool can understand, another can. So being calm, as a psychiatrist, I would say that if you look at the graph on the right, if you are sort of aroused and anxious a little bit in the middle, you will probably do well. If you are zero anxious, you will perform very badly. You won't care. But if you are very anxious, you will do badly. So all you have to do is, from with the high anxiety, you have to take yourself to the middle to perform optimally. We do courses on biostatistics in Tata Medical Center. Sanjeet Agarwal, who was actually supposed to talk to you today, he is away for a different course. So he requested me to deliver this lecture. So it's 15th to 17th July that we will be doing. You are welcome to register. It's a paid course. We haven't advertised it. It will be in the Tata Medical Center website after 1st of April. And we also do compassionate communication courses about interviewing skills, breaking bad news, communicating with angry patients, managing death, and managing work-life balance. Being a surgeon, it's not easy to manage work-life balance. If you have interest in these, by all means, email me on healthtalks20@gmail.com. We'll inform you once the courses are live and you can register. Thank you, Anshuman.
Thank you, Dr. Datta. Thank you very much for your excellent presentation. And I think future, those who are interested, they will definitely participate in your course. But it is an eye-opener to the students and the urologists of this zone, because in the DNB examination also becoming in MCH examination compulsory regulation to include this biostatistics assessment of the students. And the last 2 patients, I have found that the performance of the students in this area is very great. So for that reason, I requested Sanjeev to participate in it. You have given an equally good presentation for the students. Thank you very much on behalf of his zone Urological Society. Now it is handed over to Anshuman. Thank you. Anshuman to continue.
Sir, thank you very much for an interesting talk. Students, if you have any question, sir is still present. You can ask. This was a very interesting talk on biostat, something that we don't really hear or we don't really very much care in whole of our training. Sir.
No, actually, when Dr. Datta mentioned about streptomycin, is it streptomycin or streptokinase you wanted to mean?
I made a mistake. It's streptokinase.
Right.
Thank you, sir.
Thank you.
Thank you very much, sir, Dr. Soumitra Datta, for giving your valuable time to our class, to our program, and teaching us the basics of biostat. We'll be looking forward for an association with you for our further classes also, if required, if and when required, we will be contacting you and gaining experience from you on this topic. Thank you very much, sir. Thank you for your valuable
Thank
time.
you.
Okay.
Bye-bye.
Okay. So, students, we will go ahead with the self-assessment MCQ questions. I have prepared set of 15 questions. I'll be presenting you the questions. You will be writing down the answers there only. You don't need to tell or the end. I'll be giving you the answers also. So should I start? Okay, is my screen visible?
Yes. Yes, sir.
One minute, sir. There is some technical glitch. 1 minute. Okay, screen is visible.
Yes, sir.
Okay. So this is the first question. The virulence factor that is most important for adherence of the bacteria to urinary tract mucosa.
क्या कौन सा एडमिशन का? हाँ वो जो एडमिशन वाला है नहीं वो मैंने देख लिया ना लिख दिया उसमें पूरा.
These are the
वो तो
options.
जब रिपोर्ट आएगा तब लिखेंगे ना. रिपोर्ट तो नहीं है ना. मैं उसी लिए
Please
आपको
keep your mic unmute. Please keep your mic muted.
वार्ड में जब फाइल बन जाएगा ना फाइल के ऊपर लगा देंगे. तो कल वो आज शाम को आ जाएगा. चलो बाकी लोग आएंगे ना जैसे नेफ्रोलॉजी किसी को नेफ्रोलॉजी लगेगा तो ऊपर लिख देंगे वो अपने आप आके देख लेगा. फाइल देखने से उनका भी काम इजी हो जाएगा.
The options are A hemolysin, B K antigen, C pili, D polycene production, and E O0 group. The next question is the primary bladder defense against UTI is A low urine pH, B low urine osmolarity, C voiding, D TAM hotspot protein, and E vaginal mucosa, mucus. The third question is the validity of a midstream urine specimen should be questioned if microscopy reveals. Options are A squamous epithelial cells, B red blood cells, C bacteria, D white blood cells, and E casts. Fourth question is treatment of asymptomatic bacteriuria is most indicated in patients who are elderly, catheterized, pregnant, spinal cord injury, or lithotripsy. Number 5, the most common bacterial cause of xanthogranulomatous pyelonephritis is E. coli, Pseudomonas, Klebsiella, Proteus mirabilis, or Staphylococcus. Question number 6. The drug thought to be safe in any phase of pregnancy for UTI is A. Fluoroquinolone, B. Nitrofurantoin, C. Sulfonamide, D. Penicillin, E. Tetracycline. Question number 7. Which statement best describes the relationship of interstitial cystitis bladder pain syndrome to bladder cancer? A. Interstitial cystitis is a pre-malignant lesion. B. Is often associated with bladder cancer. C. A positive urine cytology can safely be ignored in patients with interstitial cystitis. The vast majority of reports fail to document an association of interstitial cystitis with subsequent development of bladder cancer. And E. Dysplasia is a typical pathologic finding on bladder biopsy. Question number 8. The central role of histopathology in interstitial cystitis is to determine whether or not the patient has an Hunner lesion, to help determine the most efficacious treatment modality, to predict prognosis, to rule out other disorders that might be responsible for the symptoms, and to confirm the diagnosis with pathologic criteria. Question number 9. Which of the following intravesical treatments has shown proven efficacy for interstitial cystitis in pivotal US FDA trials? BCG, lidocaine, botulinum toxin, heparin, or none of the above? Question number 10. All of the following mycobacteria cause tuberculosis except, that is genitourinary tuberculosis, except Mycobacterium bovis, Mycobacterium avium intracellularly complex, Mycobacterium africanum, Mycobacterium microti, and BCG. Question number 11. Which of the following statements is false about genitourinary TB patients? A. MRI is often used to help diagnose patients with GUTB. CT is most useful in extensive TB disease when other organ systems might be involved. The most common finding of GUTB on plain film is calcification. IVU is the best test to detect early renal changes due to TB. The most common finding on IVU is the obstructive uropathy from scarring. Question number 12. Factors that suggest a complicated UTI include all except male gender, recurrent UTI, pregnancy, elderly, or diabetes. Question number 13. Michaelis-Guttman bodies are associated with the following disease process: A. XGP, B. Malakoplakia, C. Renal echinococcosis, D. Chronic pyelonephritis, E. Acute focal bacterial nephritis. Question number 14. The most reliable early clinical indicator of urosepsis is chills, fever, hyperventilation, lethargy, change in mental status. Diagnostic first line gold standard for urogenital cystosomiasis is A, polymerase chain reaction, B, serology, C, cystourethropy with bladder biopsy, D, rectal biopsy, and E, urine egg counts. I think the questions are over. Should I go ahead with the answers? Okay. The first question was about the virulence factor that is most important for adherence to bladder mucosa. The aim of this question was basically to let you know that this is a very important topic in geo-infection. The host factors and the bacterial factors required for infection are often asked in theory examination as well. So you should read it from Campbell. It is written in great detail there. And for this very question, the answer is pili, and I think everybody will be knowing this answer. And I are present where the first adherence of the bacteria occurs with the bladder mucosa through these pili. Again, on the same line, the primary bladder defense against UTI, the answer should be voiding. Several studies have been shown, which have been done, which has shown that bacteria make their way into the bladder rather very frequently. Fairly often they enter the bladder, but colonization or infection does not occur that frequently. And one of the main reason about that is that if the patient is voiding well, this even small these bacteria usually they get washed away with the urine. So in patients with voiding dysfunction, the chances of UTI is more because of that only. So the answer is voiding. In this question, the validity of a midstream urine specimen should be questioned if microscopy reveals. Now, this is a very important question. Whenever you are asked about what investigations you are going to do, you will say urinalysis and urine culture sensitivity. The next question will be asked that how do you obtain a urine specimen for this test? And you should know midstream urine specimen is to be taken, and how in males the prepuce has to be drawn back and clean. In females, how the labia has to be separated, and then the collection should be done. We were discussing urine specimen collection in TB patients as well. So all these things are very important. One has to go into detail of these things. The answer is the presence of squamous epithelial cells. If there are squamous epithelial cells, then it means that the collection has not been done properly and it is contaminated with the cutaneous bacterial flora. So the results are not as interpretable as it should be. Then next is treatment of asymptomatic bacteriuria is most indicated in patients who are, the answer should be pregnant. In all the other groups, it is not shown to be very effective, and treatment of asymptomatic bacteriuria is not indicated in those patients. Even not in preoperative, in routine preoperative conditions, we don't need to treat asymptomatic bacteriuria until and unless we are going to breach the mucosa. A simple cystolithotripsy usually does not breach the mucosa, so it does not need treatment for asymptomatic bacteriuria. But in pregnant patients, there are high chances of development of urosepsis, so it should be treated as soon as possible. The most common bacterial cause of xanthogranulomatous pyelonephritis, very commonly known, Proteus mirabilis. It is low virulence disease, as we discussed during our case discussion. It is the most common is Proteus mirabilis. The drug that is thought to be safe in any phase of pregnancy is penicillin. Fluoroquinolones are not recommended. Nitrofurantoin, sulfonamide, and tetracycline are all dangerous for the baby. So penicillin is the most safe drug to be used in pregnancy. Which statement best describes the relationship of interstitial cystitis to bladder cancer? The answer should be that vast majority of reports fail to document any association between the two conditions. It is not a pre-malignant lesion. It is not associated with cancer. In fact, in the presence of cancer or carcinoma in situ, the diagnosis of interstitial cystitis should be questioned. Positive urine cytology can never be ignored. In no case it can be ignored. A positive urine cytology for malignant cells, it should never be ignored in any case. And dysplasia is never a finding on bladder biopsy in interstitial cystitis. So question number 8 was the central role of histopathology in interstitial cystitis is mainly to rule out other disorders that might be responsible for the symptoms. So this is very important. Where there are no telltale signs of pathological findings of interstitial cystitis. Anyway, which of the following intravesical treatment has shown proven efficacy for IC in pivotal US FDA trials? Till date, there are no drugs which are FDA approved except one oral drug, that is sodium pentose and polysulfate. That has to be remembered. All of the following Mycobacterium cause GUTB except Mycobacterium avium intracellulare complex. Even BCG can cause. So BCG sepsis one should be aware of and one should know while treating carcinoma bladder cases. Which of the following statements is false about GUTB patients? The answer is MRI is often used to help diagnose patients with GUTB. Still till date, IVU or a CT IVU is the most important imaging investigation to diagnose GUTB. MRI is not that commonly used, although it can have specific findings. It can show the specific findings of TB, but it is not very routinely and very commonly used till date. And all the other options are correct. Like the most common finding is calcification, till the best test. Question number 12, factors that suggest a complicated UTI include all except. There are several factors. There is a whole table of complicated and non-complicated UTI. How is it defined? It is given in Campbell in the Infection chapter. You should go and read that. Be remembering everything. So the answer is recurrent UTI. Recurrence does not mean that the UTI is complicated. UTI mainly when there are high chances of complications or sequelae of infections, then only it is complicated. In all the other cases, there are high chances that the infection will cause certain sequelae or certain complications. So in such cases, they are called complicated UTI. In recurrent UTI, there is nothing like that. Michaelis-Guttman body is already discussed in the discussion. Sir, Dr. Chakravarti sir asked this question. It is malakoplakia. The most reliable early clinical indicator of urosepsis is? The answer is hyperventilation. The most important part of this question is to understand what urosepsis is. UTI is different, colonization is different, infection is different, urosepsis is different. Urosepsis is involvement UTI plus some organ damage, the generalized effect of infection of sepsis. Now, for this, the early clinical indicator is hyperventilation, chills and fever occur in simple UTIs, simple acute pyelonephritis also, and lethargy and change in mental status are usually the late signs, not early signs. So hyperventilation should be the answer. The diagnostic first line gold standard for urogenital cystosomiasis is answer E, urine egg counts. It is the most direct way of diagnosing cystosomiasis and it is the gold standard. The presence of eggs in the urine, cystosoma egg in the urine, is diagnostic. There can be nothing else but cystosomiasis in that patient. Thank you. I think with this, we have come to the end of our session today and we are well in time. Dr. Ranjan Desai, it's 1:19 p.m.
Yes. Yeah, it's excellent conduction, Anshuman, and I'm very happy. All the teachers and students, they have really participated actively And our purpose of involving everybody into academics has become a partly successful with today's performance. Hope all of you also enjoyed this session. I thank all the teachers, those who have participated, Professor Sudip Chakraborty, Dr. Animesh Kumar Das, Professor Ranjit Das, and also the students, those who have participated and those who were also present during the session, along with Dr. Anshuman Ashu. I thank all of you. Hopefully we'll meet once again in the next weekend, Saturday, with a very important topic of the renal stone disease, and we'll see you once again then. Thank you very much.
Thank you, Anshuman.
Thank you, sir. Thank you very much.
Thank you, everybody. You conducted very nicely, Anshuman. Last part, this quiz portion, this was also quite useful, quite educative. Thank you.
Yeah. Thank you, Sudipta.
So can I leave? Can I leave? Okay, thank you.
Yeah, yeah. Everybody can leave. Thank you. Bye. Bye.
Thank you very much, sir. Thank you, everybody. Thank you, students. Thank you, teachers. Thank you, Ranjan Desai, for giving me this opportunity. Thank you very much, sir.
So